This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.
Welcome to today's meeting of the Health Committee. Members of the public may like to follow at London. I'll carry on, see if that gets sorted out.
Chair, you may want to adjourn for one moment because I think Botai may need to just come in probably to make that.
Before we begin, I'd like to inform members of this committee and our guests that we are participating, along with 25 local authorities, in a pilot of Minute, an AI transcription and summary tool developed by central government. The recording of this meeting will automatically be transcribed and summarised by the tool for comparison with minutes drafted by the clerk in the usual way. Members therefore won't see a difference in the usual meeting service provided, but it will allow us to participate in behind-the-scenes evaluation of the tool. If you would like to understand more about the pilot, please contact the meetings clerk. The main item on the agenda today is men's mental health in London. However, we have a few short items of business. Can I first ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chairman. No apologies for absence have been received. However, in accordance with Standing Order 2.4, Assemblymember Ahmad will participate in the meeting virtually today.
Thank you. Moving on to declaration of interest, can we note the list of offices held by Assembly members? Thank you. And can I also ask members if they have any disclosable pecuniary interest in any specific items listed on the agenda? Thank you. Membership of the committee, terms of reference and standing delegations. Can we note the membership and chairing arrangements of the committee, the terms of reference and the standing delegations as agreed by the London Assembly at its annual meeting on the 6th of May 2025? Thank you. The minutes of the last meeting. Can we confirm the minutes of the meeting held on the 5th of March 2025? Thanks, Krupesh. Summary list of actions. Can we note the closed and completed actions arising from previous meetings of the committee and the additional correspondence sent and received? Thanks. Action taken under delegated authority. Can we note the actions taken by the former chair under delegated authority in consultation with group lead members to agree A, the end of life care in London report, and B, the getting to zero by 2030 HIV in London? Thank you. The response to committee outputs. Can I ask the committee to note the responses from A, the NHS North West London Integrated Care System, the NHS North East London, the Minister of State for Care and the NHS South East London Integrated Care Board to the committee's report on the state of dentistry and oral health in London, and the response from the Mayor of London to the committee's report on gambling-related harms in London? Thank you. Apologies, guests. It's been a little while since our last meeting, so we've had a bit of an update to run through there. But moving on to our main item of business today, before we begin our discussion, we'd like to note that some of the content may be triggering or difficult for listeners. We therefore would like to urge anyone who may be affected to seek help, for instance through the Samaritans or Mind, both of whom have representatives here with us today and who offer 24-hour help and support. I'm sure that our other guests will also be discussing the support services that they can provide. I'd like to extend a warm welcome to our first panel of guests joining us to discuss men's mental health in London. That's Amy O'Connor, Global Lead Policy and Advocacy for Movember, Jackie Morrissey, Assistant Director of Policy, Practice and Influencing Programmes at the Samaritans, Dr. David Palmer, Chief Executive Officer, Mind in Bexley, and Simon Dolby, Fundraising and Development Lead, Mind in Bexley and East Kent. Thank you all for joining us today. We really appreciate you giving us your time. So I'd like to kick off the meeting with a question to all of you. Perhaps, Amy, I'll turn to you first, having introduced you first, and ask what distinct mental health challenges do men face compared to others, or just in generally distinctly for men?
Thank you for the opportunity to be here today. For anyone who doesn't know, Movember is one of the world's largest men's health charities. So we look at men's health across physical and mental health. And I'm here today representing the 97,000 Movember supporters we have in the Greater London area. A great first question and not a simple answer, as I'm sure you'd have noted. There are many factors that contribute to common mental health problems we see in men. These range from men having less healthy lifestyles to start with, men having more risk-taking behaviours, which is part of their socialisation from a young age, a lack of or lower levels of health literacy within our men, so that ability to understand when they are seeing symptoms of health risks, or moving on from that, being able to articulate those symptoms. Help seeking, so when they have recognised those symptoms, actually coming over and seeking help for them. And then finally, a health system that knows how to understand and adapt to the needs of men. So this kind of continuation of several factors is what's seeing rates like, 3 out of 4 suicides being men, and a really different experience that men have of our healthcare system versus women. I can go into each of those answers in a bit more detail because, there's a few factors that I presented there. I think it was 6 different reasons. I don't know if you want me to do that now or if you want to hand over to the word. I don't want to hog the time.
I think that's a really nice overarching.
Yeah.
We'll come into the questions, but I think that's really good scene setting, I think, for the moment.
Perfect. The only thing I would add then before I hand over, and I'm really happy to go back into all those pieces, but the thing that is underlying all of those kind of factors that you're seeing there is the role of traditional gender norms. And you'll have seen a lot in the press recently, you'll have been part of conversations yourself. We are talking to members of City Hall about the role of masculinity when it comes to men's health. Gender roles are changing in men, but there are also some kind of embedded traditional gender norms that are why we're seeing those lower levels of health literacy, health-seeking behaviour, engagement with health services being completely different to how maybe women would approach. So I'll probably talk a little bit about gender norms throughout the session today, and it's something that we're investing our time into understanding at Movember.
Thanks. And we are getting into question on that very soon.
Thank you.
Jackie.
Hello, and thank you for inviting us to be here today as well. So I'm Jackie from Samaritans, which is a charity working across the UK and Ireland to prevent suicide. We have a whole number of branches within London, working to provide both our helpline but also a whole range of different outreach activities to try and ensure that we're reaching people where they are. And I suppose the most stark challenge we have is around suicide. So it's the biggest killer of men under 50. There were 6,069 suicides registered in England and Wales in 2023, which is the latest year for which we have data. And in London, that's 570 suicides registered in London. And London actually has the lowest regional rate across the country. So the highest rates are in the northwest and the northeast. So London has a rate of about 7.3, which is per 100,000 of population. But that's still, between 2021 and 2023, that's still 1,180 men who died by suicide in London during that time. And that's about 10 people a week. And the important thing, there's a lot of numbers in there, but this isn't about numbers, this is about people. So these people, they're somebody's son, someone's dad, someone's brother, someone's best mate, someone that they've worked with. And for every suicide, it's estimated that about 135 people are affected. So we know across London, different boroughs have different rates, but again, it's a problem across London, and it's an inequality issue, which is the thing I'd really like us to think about today. So the highest rates affect the poorest men living in the poorest areas. And it's often a complex combination of risk factors, so financial difficulty, economic adversity, social isolation, loneliness, but also some of those behaviours which Amy mentioned, so perhaps alcohol and drug misuse, gambling, interaction with the criminal justice system. So a whole range of different factors were often contributing. But what we hear from men and what we see is that a suicidal crisis is often driven by really difficult life events. People don't think about it men aren't thinking about it as having a mental health problem. They're experiencing these difficult life events like a relationship breakdown, losing a job, maybe problems with benefits or housing. This really difficult problems that's just leaving men feeling like they can't see another way out of the problem. So they feel they have no choice but to take their own lives. They may be feeling they're a burden to others, feeling that perhaps people are better off without them and that they don't belong. So when thinking about how do we prevent suicide, we have to address this whole range of factors alongside thinking about mental health.
Thank you, Jackie. And David?
Hi, thanks for the opportunity to speak. I think our previous speakers have highlighted the main issues. I think the one overriding issue is societal stigma, and traditional methods of masculinity discourage individuals from expressing vulnerability and accessing service provision. And we know from the data around the suicide data and the data around secondary care and also issues relating to the criminal justice system that men tend to seek help at an advanced stage, at an acute stage. So I think there's lots of issues in there around stigma, which is heightened by the hyper-masculinity discourse of Andrew Tate and others through social media, and the use of echo chambers highlighting these messages and having a discourse which alienates other discourse and narratives. And I think so. Social media, I think, is a significant impact on this, particularly for young people. I think all the issues related to poverty, inequality, issues around employment, stress at work and in the workplace, education achievement, all of these factors impact significantly. But I think the overriding issue for me is societal stigma, both society having an understanding of mental health across genders, and then that becomes a self-stigma where individuals won't access service. So I think these are the main issues.
Thanks, Simon.
Yeah, I think just really to echo what previous speakers have said, it's in essence it's that alpha male syndrome that men, are cavemen and mustn't admit defeat or pain or any sort of fragility to each other. That seems to be still prevalent, even though it's a modern enlightened society we like to think we're in. But it's also that weaker support network. One of the projects that I'm delivering is a barbershop project, and when you look at unisex salons and just the range and that element of support and discourse that is going on and conversation are going on with women having their hair cut in the stylist chair and glum man not opening his mouth, sitting next door to them, it just really brings it home. And we get that at quite an accelerated degree with our Veterans Project as well, where that alpha male syndrome just is up another notch. I fought for my country, how can I possibly admit defeat or fragility in any shape or form to you? And as David says, that manifests itself with men leading it right to the wire in terms of physical health issues.
Thanks. And then to come back to everyone on the panel again, I guess we've touched on it a little bit about demographics, especially around poverty, where there might be a disproportionate effect. Are there any groups in London where we see a disproportionate effect on men? And are there any specific London challenges or things happening in our region which affect men's mental health that perhaps are not seen in other regions or are unique to London? Amy?
Yeah, I can jump in with a couple of points there. I think just building on the norms piece before we go into that, an understanding of traditional and masculine norms also having a protective health benefit as well. So I think we're often very quick to jump in and say, we know that stoicism, independence are strengths that we see in men that may stop them from help seeking. If we build services that lean into the positive aspects or the strength-based aspects of masculinity, we do see success there as well. So if you think about men being if they are stoic and they've signed up that they're going to do a 10K run and they're going to be training for it every week and it's absolutely throwing it down with rain and we're leaning into the stoicism because that's going to keep them healthy, then we can start seeing improved health outcomes. And a programme that does that comes into your question is one that's led out of the University of York called BALM, B-A-L-M, which works with NHS frontline workers. And it leans into those protective masculine qualities. So it's practical, it's collaborative, it's action-oriented strategies. It's built with men in mind, and it partners NHS frontline workers with colleagues for peer support for low mood, anxiety and depression, and the outcomes there that they're starting to see when they've built this programme with, you know, traditional masculine norms in mind are really quite staggering. So I think when we're looking at London populations, to bring it back to your question, looking at our frontline workers, so you know, the jurisdiction of the Met Police within this office, our firefighters, our NHS workers, our other kind of audiences that we know see more trauma, experience more distress, might have that lower mood and anxiety that the programmes like BALM confront, alongside the kind of the groups that we've mentioned today. I would also say London has, as a capital city, a younger population than some of our other areas across the country. So looking at the experiences of young men, we've already heard from colleagues around masculinity influences is a topic being discussed a lot at the moment. We've just released a report a few months ago about the experiences of young men online. Over 60% of our young men are experiencing men and masculinity influences at the moment, and we spent the time listening to them. We listened to over 3,000 young men about what their experiences are online, and again, it's a interesting, nuanced findings in that they are getting some positives out of them. They're feeling motivated, they're feeling connected, they're seeing these influences as role models, but we also know that these influences can be damaging the mental health of our young men as well. So there is a real need to think about our, you know, in the results of this piece of work, to think of a life course approach, and when we're thinking of our young Londoners, thinking specifically what are we doing for our young men and what are we doing for our young men online, and Movember are working on a heap of solutions there we're happy to talk you through.
Thank you. So I suppose specifically that's a focus on young men as a demographic. Is there any other demographics that perhaps we haven't touched on? Jackie?
So again, thinking about suicide specifically, I think the other couple of communities which are really important to think about are the LGBTQ plus community, where you see a higher risk within that community, and that's really thinking where people are experiencing mental ill health, which obviously a known risk factor, but also that inequalities in healthcare treatment among those communities, so that people perhaps are receiving inappropriate care or actually stopping to seek help altogether. The other community which is really important to think about, I think, is around racialised communities. Again, we've got a great diversity within London, but what we see in some of the evidence shows that people from different ethnic groups don't always receive the same support from mental health services. So, for example, young people from minoritised ethnic backgrounds are less likely to receive specialist assessment following self-harm compared to white young people. And also we're seeing that people from minorities' ethnic backgrounds can only be seen, or can sometimes be seen by mental health professionals to be at lower risk of suicide, because perhaps they're thinking about one way that suicidality is expressed, rather than the fact that that can really depend on people's cultures, people's beliefs, people's backgrounds, like how they express themselves. So there's a really important piece here around recognising diversity and recognising that within different communities that risk may be playing out differently and not being recognised well.
Jackie, could you expand on that at all? Just, you said it plays out in different ways. Could you expand on how it would be different?
Yeah, well, some of the issue is actually the data, and us not knowing enough about how it plays out. So if, again, thinking about racialised communities, what we do know is that rates are highest among white and mixed ethnicity groups, but that obviously covers lots and lots of different identities within that. And one of the problems at the moment isn't there isn't enough ethnicity data. So we don't know enough both about who dies by suicide from different ethnic groups and communities, but also why that is. So some of the things I've just told you around that evidence about not getting access to care, like we need to know more about that and really be able to understand that better. And that feels particularly important in a London context to try and understand that more.
Thanks. And the link to male suicide, because you mentioned your opening about that like the tendency towards risk-taking behaviour. Is that why we see more male suicide, or is there another driving factor behind why perhaps there's a higher rate of suicide?
It's a really good question, because as you say, so men are more likely to take their own lives than women, so 3 times as many men, but women are more likely to attempt suicide. So one of the things, there's kind of quite a lot of questions about why that might be, but one of the things is about method and lethality of method that people choose. And we can provide perhaps some more information in writing around that rather than now.
Thank you. And Amy, did either of you to come in on the
yeah, just another group is, asylum seekers, and we know from the data, the shocking mental health related to the pre-migration process, so and the actual process of arriving here and the trauma related to that, with high levels of PTSD known for this particular group. And also, I have, in a previous role, I did a lot of work with Somali and Ethiopian communities in London. And I think, these are communities which traditionally don't access mental health support due to cultural norms associated with mental illness and mental ill health. And I think, I know there was very high suicide rates amongst the Ethiopian community in London up to 10 years ago. And a lot of that was down to apparently post-migration factors relating to unemployment, lack of status, challenges around housing and adaptation, racism and discrimination, and not accessing primary care, which is obviously the gateway into mental health support in the UK. So I think it's also important to recognise some of the challenges for post-migration factors on communities and the impact that has on mental health.
Thanks, Amy. And sorry, David, come back to you to talk more about the gender norms that we wanted to get into earlier. And I think, David, you'd mentioned about perhaps the rise of Andrew Tate and the impact of that. I mean, to my mind, it was almost like there was that issue before, and there's a space, and it's being filled by those. So it's almost like there was this kind of issue around gender norms and masculinity beforehand, as opposed to saying that's now why it exists. I mean, is there anything you would say further around the impact of gender norms and masculinity on men's mental health?
Yeah, definitely. Thank you. Andrew Tate is used as a bit of a one-man individual, because we all know what we're talking about when we say Andrew Tate. We use the phrase is men and masculinity influencers online, because this problem is a lot bigger than Andrew Tate. Being a men's health charity with a community of fantastic men and women who've kind of turned up for us for 20 years now, we always look at a strengths-based approach and what can we learn from what our young men are seeking. We know the role of being a man has changed in the last 50 years. I think from what we learned from our Young Men Online report is that our young men are seeking information on how to be a man in 2025. They are seeking information on how to live in good health. They are seeking information on how to have a romantic relationship. And they are going to the resource that they have grown up with, which is their phones. And that gap, as you say, is being filled with masculinity influencers who are speaking directly to them in the language that they speak. So I spoke a moment ago about that kind of behavioural action model that fantastic researchers like Paul Gaudas at the University of York are taking to connect with men, because they know that's the language men speak in. We also see that from some of our influencers, 5 ways to do this, 10 ways to do this. They are going to where men are and searching for information, and they are speaking in the language that men resonate with. What I think we can take from that is our young men are searching for this, and there is a gap to fill there, and we can change the narrative around what we are providing them. So one example, Movember did a huge amount of work with online influencers. We've got more work coming up via kind of a lab opportunity, working with other influencers online. But we worked with a group of 9 influencers in the UK, some of which were from London, to present a different alternative narrative to our young men. And it wasn't about lecturing them on, mental health. It was about role modelling good behaviours. So we did a series of content where we had our young influencers role modelling positive, vulnerable behaviour, talking about their mental health, on their YouTube videos, you know, and the second they went up, they had millions of hits and were some of their most successful pieces of content. So this was a partnership with a healthcare charity, and it was some of their most successful commercial content. And because our young men are looking for it, they're looking for role models, and there is an opportunity to both fill that gap with an alternative narrative, but also look at the algorithms that are reaching our young men and what is redefining what is harmful content, and looking at how that is continuously kind of reaching our young men online. And going to where they are, like I say, online as well. There's a lot of conversations around what's happening in schools, and some fantastic programmes. We work with our partners Beyond Equality, who do great work in schools, but there is also a need to, like I say, go to where men are, which is when we're talking about our young men online. Does that answer your question?
Yeah, I think so. And I suppose the follow-up be, you say, I'm sure as well, that the statistics show men are less likely to seek help. But what it sounds like you're saying is that men are seeking help, but perhaps the format through which they're seeking that help or that advice is different. And so there needs to be an adaptation to provide that advice.
Yeah, exactly that. Everyone who works at Movember around the world will tell you that if you speak the language of men and talk to them about their health, sometimes you can't get them to stop, which is fantastic. At our community events, you know, there's huge amounts of discussion around men's physical and mental health, but it's about doing it in the space and the language that men resonate with. And there's lots of programmes that we fund here in London that we partner with. You know, Men Sheds are a great example of that, of, you know, speaking to men in the language that they respond to. I think the other thing to note is there's been a lot of conversation about asking men to seek help, but we're not always putting the services in place that then respond to them when they do. And so this is a cohort that aren't always as trusting of the healthcare system, especially in some of those groups that we've been discussing on this panel. If you get them over all of the gendered norms and the traditional gender norms so that they turn up for help and then you don't provide gender responsive healthcare, you are really failing men at that point. We did a piece of research that was launched last year called the Real Face of Men's Health Report, and I think it was, I'm pulling the stat up now, 58% of men in the Greater London Authority experience negative bias when it comes to health services. When it comes to suicides, we know there's staggering numbers of men who have took their own lives who have been engaged with their GP. What we need to be doing is, yes, getting men into the health services when they need that specialist care, but also equipping our clinicians with an understanding of men in their clinics and how they can respond to men in a gender-sensitive way so that they're not falling through the cracks at the point of help seeking.
Thanks. And one final question from me, and I'll open out to the panel after, but there's almost, it feels anecdotally, a kind of mistrust from some men that there's some lip service around men's mental health, but men's health in general isn't top priority or where people actually see themselves fixing the real struggles that men face, perhaps in life. Is there an answer to that? Is there a way in which we can build that trust that says we do, you know, as a society, really value men and men's mental health?
Yeah, I think there's lots of ways we can do that through the conversations we're having with our young men online and showing that we're listening, that we know that they're having some positive experiences online, all the way to national strategies. So we have the men's health strategy. The first men's health strategy for England is hopefully coming out later this year. The call for evidence is currently live. I think that's a great example of, you know, UK government saying we recognise there is an issue with our men, that their health outcomes are falling far behind our women in certain areas, and that in the same way we have for women who desperately needed that kind of gender responsive care, that women's health strategy to support them, we need to put the same provisions in place for men, and investing in programmes that are built with men in mind. You know, Men Sheds, we run programmes, Chai in the City, Brothers Through Boxing, spaces that have been specifically designed for men, and investing in those programmes, investing in sports-based programmes really shows that we're listening to their needs and responding to them. Does that answer your question? Is that helpful?
Perfect, thank you. Simon?
Yeah, I suppose it's a two-edged sword. Just as influencers are out there able to suck up the conversation, at the same time, the traditional relationship between us as patients and our GP is dramatically different from 50 years ago. You would have had a relationship with your GP; they would have known you. Now you can't. You don't even know if you're going to A, can you get an appointment, and B, you can't guarantee in any shape or form that it's going to be any continuity. And I suppose that's why one of our particular projects, the Barbershop Project, we know statistically that men are more likely to talk to their barber than their GP about mental health, and it's down to the relationship. We care about our body image. Men are no different in that. We've got the same vulnerabilities and same sort of social pressures. So when you find somebody who can quaff you the way that you want, they're like gold dust, and you are ever so loyal to them commercially, and that is a relationship that you can build on. And so that particular project that we deliver, it's all about then equipping the barber with the right skills to be able to spot signs of anxiety, depression, and signposting, empathetic conversations, that sort of thing. But there isn't the health service isn't able, it seems at the moment, to be able to sort of go where it ought to be or where it traditionally used to be, and so we are having to adapt. And so that's why projects like that are coming along to try and fill that void. But yeah, it certainly is a challenge.
Thanks, Simon. We're going to pass over to Assembly Member Boff.
We have touched on the role of stigma in terms of men seeking help. So I'm going to pass on that set question because it's already, I think, been well covered. But what action can be taken to address the stigma? Who would like to come in on that, addressing the stigma? Ms. Morrissey.
Thank you. I think one of the important things, just kind of following on from where we were and then coming to that question, is this question around help seeking, isn't it? So at Samaritans, we take 3.3 million calls for help every year, and around nearly half of those are from men. So men are definitely seeking help. But we saw a national study that looked into suicides of middle-aged men, and what that found was that 9 out of 10 men were in contact with a part of the system before their death. So for me, there is men are already somewhere in the system, these men who are at highest risk, they're in contact with services in some way. And I think what we'd like to see is that this kind of no wrong door approach, so that actually men have kind of combated the stigma, they've got in touch with the system. It's probably not about their mental health, it might be about something else. But then what we're not doing is spotting the risk. What we're not then doing is ensuring that risk is picked up and then men are supported to get the support that they need. So that's the bit we're really worried about. And then one of the things we did a piece of research with men and who were suicidal, and asked them how to design support services that they would feel was very accessible to them. What is it that might combat some of that stigma, how to get them engaged in that. And what they told us was they really wanted activities which facilitated conversations together with other men, like having these kind of peer-to-peer spaces which actually initially had quite a low commitment. They weren't committing to kind of 10 weeks of something. They were invited along. They were able to go to something with a low commitment that perhaps had a sense of reverence, was a bit fun, but where they could foster these meaningful relationships over time and develop a sense of achievement, doing things with others where they then built relationship and then they talked through what was going on with them, but whilst doing something else, quite possibly at that time. So, thinking about that stigma question, it's the kind of men in sheds model, isn't it? If you get people coming together to, make something or mend something or do something, that they're not reaching out for mental health support, they're doing something together which is practical. There's some really interesting examples of men, for example, who need legal support, perhaps around a relationship breakup, perhaps around getting access to their kids, and then going and getting legal support. But whilst they're waiting to get that free support, what they're doing is talking in a conversation with other men in a kind of peer group again. So creating these spaces where men are getting really practical support, building connections with other men, fostering these relationships, and then that really kind of supporting them in their mental health.
I mean, thank you for pointing out that actually, men are seeking help, and the records do show that the number of suicides, if that's one measure, the worst measure, of course, of male mental health, that they are reducing in general. And so something is being done right. And what do you think that is?
I mean, around suicide prevention in London, there's been some really interesting work with Thrive London, with local multi-agency suicide prevention groups, with organisations like Mind and Samaritans, who are doing, I think, a whole range of activities, including, for example, some of the work Local Samaritans does in London is outreach work. So going to places where people are struggling. That might be going to local police custody suites. That might be going to food drops to try and support people who are homeless. That might be going to a deprived housing estate that has a health and wellbeing day. But being in places where there are men who are struggling and then being there in order for people to talk to them. One of the interesting examples I was told, actually, was around some work our Harrow branch are doing with City of London Police, who have a welfare tent in Bishopsgate. And that's actually about promoting women's safety. But what they're finding, I mean, that they'll talk to anyone who comes to the tent, obviously. And what they're finding, actually, is that the majority of people who are coming to talking to them about how they're doing are men. And they think it's because it's not a planned conversation. It's not come along and talk to us about this thing. It's a kind of an opportunity, walking past and then thinking, oh, I'll start up a conversation. So there's some really, I suppose men are not a homogenous group, to say the obvious, but there's a really nice kind of diversity of different activities going on, I think, across London, with lots of efforts being put in specifically to create spaces and different opportunities for men to talk.
Yes, please, Mr. Dolby.
In terms of stigma, I think certain workplaces as well, there are big issues. Certain professions, car dealerships, construction sites, the law. We talked about people going in and having legal support alongside mental health support, perhaps. And in fact, I've just been we're in conversation with one of the law societies, and they're really, really worried about young lawyers. It's hyper pressure, and you cannot admit fragility because otherwise your probation doesn't get signed off. You cannot get the next promotion because of admitting mental health pressures, because that could affect your employability. So one of the ways that we're looking at that is we've introduced an ambassador initiative, a wellbeing ambassador initiative, which has got tiered levels of support and training so that you can help others. But actually, we think for the legal profession, we're disguising this so that the young lawyers are looking like it's a philanthropic perspective. They're taking this training on so they can help others in the practice. But actually it's for them, because often, with mentoring, for example, the mentor gets as much out of it as the mentee. That's a very sort of recognised sort of issue in those sorts of one-to-one setups. And so it's how do you tackle stigma when nobody wants to admit there's a problem, when everybody knows there's a problem. So it's sometimes we're having to disguise it, I suppose.
Other cultures seem to do it quite better. I mean, in California, there's virtually nobody who's in counselling, and it's something that's in conversation. Whereas if you say that you're in counselling in London, people think, well, what's wrong with you? Is that what can we import about that relaxed attitude to
Yeah,
seeking help.
it's just a societal issue, isn't it? And I think we're all collectively trying to beat the drum in trying to encourage those positive conversations around mental health in Movember. And we do a Wear It Blue, our logo's blue, so, wear blue, do your selfies for social media, have those positive conversations around mental health. There's that collective effort to try to normalise these positive conversations. But it does seem that no matter what we do, there's always so much more still to do. And as I said, some professions are not helping us.
Yeah. Now, what do you think the Mayor could do about addressing particularly this stigma? Because I seem to remember many years ago, under the previous Mayor, there was a drive to put public health messaging at the end of platforms where they identified as being places where people could find themselves in mental distress. I haven't seen those for a while. I wonder if any of you know about that initiative or why it's not there anymore, because there don't seem to be any public health messages on the transport system at all. Perhaps, Ms Morrissey, I mean, Samaritans would be the one who'd take the advertising space, wouldn't they?
Well, we have, I can't speak specifically to the Mayor's initiative, but we certainly have a big partnership with Network Rail and the wider rail industry. And that partnership has a whole range of things that we do. So we trying to encourage help seeking by campaigns which are often targeted at men. And we've got one, for example, that was called Real People, Real Stories, which was all about men sharing their stories. And you would see that campaign across the whole rail estate. So it wasn't about ends of platforms, it was about all different places across the rail estate. On the back of tickets, for example, or in stations, you would see on the radio, a whole set of things.
And that's something you've got some positive feedback from?
Yeah, absolutely. And another aspect of our work with Network Rail was a campaign called Small Talk Saves Lives. And what that was doing was try to encourage all of us that actually just a little conversation with someone can really make a difference. So if you see someone who looks like they're in distress or they're struggling at a train station, go and ask them anything. Ask them about the weather or a coffee.
Yeah, I think London Underground have taken that training programme, which is trying to identify people who are stressed and may need that work. It's more about those general messages that are you basically, to sum it up, are you saying that would that initiative work if it was applied for Transport for London?
Yes, so I think there's a range of things, aren't there, in your question? So there's evidence that shows encouraging help seeking through help seeking campaigns works. There's evidence that shows you can build people's confidence, you can but you have to have the services there that you're pointing people towards, don't you?
Absolutely.
But it does work. You can encourage men to seek help through those campaigns. And there's lots of different elements of health, which I'm sure Amy can talk to, where you've seen campaigns really creating this behaviour change in different groups of men. So yes, absolutely, that does help. And there have been, I think, a whole range of different things in London which have happened around that, whether it's specific to the transport network, and I can only talk to our Network Rail experience, but yeah, that's been successful.
But the Network Rail experience was a positive one. Dr. Palmer.
Yeah, no, I absolutely concur with what you said, Jackie, and I think one of the very successful campaigns around normalising discussions around mental health was the EFL partnership, so the English Football League with Mind, which I think lasted for about 3 to 4 years. And that also sort of worked through a grassroots level, which is what we've done in Bexley, working with Charlton Athletic, Welling United and Erith Football Club, to try and normalise conversations in mental health. And I think there's a lot of messaging done, of course, through online platforms. So we've talked about, Simon's talked about the Ambassador programme, which is mostly digital, about generating awareness. And there's definitely been an increase, I think, in mental health training and mental health first aid training in the workplace to generate awareness amongst employers. But I think the key message is that it has to be long-term. The funding needs to be long-term. So, you know, the Time to Change initiative was very, very successful in highlighting sort of common mental health disorders and promoting dialogue to generate awareness, and sadly that funding stopped. So I think we need to be looking at more funding around more preventative spaces. And just going back to something that Jackie and Amy mentioned, and Simon, it's really important that we acknowledge and work with men's spaces, you know, football clubs, the Barbers Project. There's a lot of work done in the United States showing how effective these have been in terms of engagement long-term with service provision, but also looking at physical health as well, you know, and because you can't separate the two. So we know that people with really poor mental health have got really poor physical health as well, and vice versa. So I think there's a lot more can be done through public health messaging, and we need to be thinking long-term, and whether that's through, you know, bus stop advertising, or working with football clubs and the EFL. But I think we need to be engaging with men's spaces in particular.
Thank you. Mr. O'Connor.
Yeah, just to add to that, I think you asked what's special about London, and I think sport is a fantastic opportunity in London. We have a programme called Ahead of the Game, which is very much working in the prevention space with young men, young people aged 12 to 18. And we partner with Tottenham Hotspur Foundation, Fulham Foundation, Crystal Palace Foundation, who all understand the unique ability they have to reach men, and also that grassroots level as well. So we deliver this training not just with young players to help build their mental health literacy, so knowing what, you know, good mental health looks like. We talk about mental fitness. You know, at some point your mental health is going to be fitter than at other times, like your physical health, using that language that our young boys use. But it's also an opportunity to provide training for our parents. So they are, you know, the dads of our young men as well. There's a really beautiful opportunity working with dads and young men, but also the coaches, you know. And I was at a session not long ago where one of the coaches who'd been working with the young men for years and years and years, you know, seen players go through the ranks, fantastic footballers, who said to me, I'm really worried that I've been saying things that have been not helping these young guys, you know, telling them to toughen up and man up on pitch. And he was like, this training here today has really made me rethink how I'm communicating with our young men. So I think sport is a fantastic opportunity. I'll quote a colleague who says, we can't football our way out of this. You know, football can't be the only solution to men's mental health, but sport is a really fantastic opportunity.
Yeah, well, as we said, men aren't all the same.
Exactly.
Football bores me stupid.
I suppose my final reflection on what can the Mayor of London do. Yes. I suppose because mental health is in every regard, you know, the Cinderella compared to physical health. I guess it's trying to come up with innovative ways to throw money at it. There's no other. Well, it's a coordination issue, but there's also funding.
I'm at risk of trampling on another person's question. I just wanted to address the stigma, what the Mayor can do to address stigma, and that's it. But thank you very much. Thank you, Chair.
Thank you. Just, Jackie, just a quick point on the partnership with Network Rail. Is that something that is almost back office as well as front office? Because I was thinking in terms of looking at TfL and the larger male workforce. Just wanted to confirm it's for both customers and the workforce.
Yeah, absolutely. So we do a whole load of training with Network Rail as well to ensure that, well, and across the rail industry, both to boost staff's confidence to talk about suicide, to, you know, talk to someone at a station, for example. But of course, what that does, it's equipping people to think about it for themselves and for their family and for their friends. So hopefully what you're getting is this really positive ripple effect whereby you're challenging stigma, you're challenging some of the myths that there often are around suicide, and you're building confidence and getting people to talk about how they're feeling. So yeah, absolutely, it's definitely about both the workforce and then people who are using the rail network.
Thank you. I see a recommendation coming already. Assemblymember Harani.
Thank you. Just linking to a few things that have been mentioned just in the last few minutes. So I think, Jackie, you mentioned something about a violence against women and girls initiative where men got involved in the conversation as well, but also about the TfL estate, which was mentioned a moment ago. There was a major campaign, a Have a Word and Make campaign, which was about challenging some of those issues around masculinity. Did anyone come across that campaign in particular, and what do you think about campaigns like that that challenge those sort of societal practices that are creeping up and attitudes towards women and girls? Simon, you sounded like you'd seen the campaign.
Yeah, I remember seeing it. Yeah.
We spoke with some of the colleagues who were working on that campaign, and they shared some of the details, and there's no doubt the reach and the positive intent. We also shared some research around the maybe unintended incomes of bystander activations. So the positive impact maybe on intention and reach, but how we actually measure behaviour change within the men who might be behaving in that way. So we shared that research with colleagues as well. And I think we need to always think about how we're building these campaigns with men, with communities of men, and think about what we're doing for men holistically. So a lot of the time you see work that is calling men out, and what are we also doing to call them in and showing our support of men, whether that's through health strategies, through men's sheds, through specific campaigns with Mind, kind of think about men's health and our engagement with men more holistically, so we're not talking to them in one way in one campaign perhaps, and then doing something quite separate in another part of the department. And that's partly why we were recommending a national men's health strategy and national leadership, you know, a men's health ambassador for England who is looking kind of holistically at the comms and campaigns that are being built with men and going out to them as well.
Okay. Assembly Member Ahmed? Hopefully it's going to appear.
Yes, hopefully you can hear me. Thank you, Chair. My first question is to all of our panel, and good afternoon, panel. What I'd like to know is about the respective programmes that you run. Now, I am aware that you have touched on quite a few of these. This is an opportunity perhaps to do a deep dive, and I'm also aware that on our panel we do have two representatives of the same organisation, one on a local level and one on a regional level. So I'll let you sort out how you're going to answer these questions. So what I'd like to ask you is, what programmes do your organisations run for men in London? How do these work? What impact have they had, and what learning have you taken from them? I wonder if we could start with Amy, because Amy, you have mentioned quite a few of the programmes that Movember runs, and also you might want to go into them a little bit more.
Sorry, I'll start at the prevention end. One of the programmes is Movember's Ahead of the Game, not just with footballers across the sporting profile, but this is one of the most evidence-based programmes working with young men on their mental resilience. The scalability of it, we work with Rugby League Cares as one of our partners. It's fantastic for scaling, and in terms of kind of output after the sessions, we see 94% of people who attend the session, so that's, like I say, young men, but also their parents and coaching, have a better understanding of the importance of being mentally fit and healthy after those sessions. They have a better understanding of who and where to go to for help and support if they do start seeing those signs of poor mental health, and they also have a better understanding of those mental health outcomes as well. And we're also talking to partners such as the National Academy of Social Prescribing about how programmes in the community can, you know, link back in with healthcare services. So how can services, you know, refer into these types of programmes, and the same for a number of those programmes, men's sheds included. How can we provide, you know, really strong programmes like Ahead of the Game, and then how can we refer back out to them as well? So Ahead of the Game is one that we run globally, actually, so it's across sports around the world. We just received some funding from the Australian government. They've just made one of the largest investments into men's health for lots of different organisations, and Ahead of the Game is one of those programmes that is being scaled across Australia at the moment. You mentioned other countries are doing lots of great work in men's health. Another piece, I think, in the systems note, we talked about, the number of men who are seeking help for mental health, who are turning up in clinical settings and maybe not getting the support they need, and either, using maladaptive coping mechanisms because of that, or, unfortunately taking their own lives in some of those most striking of stats. We have a programme called Men in Mind, which is clinical training for mental health professionals at the moment. We're looking to roll out more so in the UK, but you asked about evidence of the programme. 81% of clinicians that go through that online training programme where they are learning about masculinity and how men turn up in a clinical setting, 81% of those clinicians reported increased confidence in engaging men experiencing suicidality compared to kind of 40%, 47% at baseline. So for an online training programme looking specifically at men's mental health, we're seeing some really positive outcomes of that, and we're trialling it, hopefully trialling it in the UK soon. And then the third one isn't a Movember programme, but you asked us to think about really specific London programmes, and we work and know of the work of James's Place, which is a London-based charity offering immediate, no referral needed therapy for men in suicidal crisis. They've got a place just off of Old Street there and are doing fantastic gender-responsive work for men as well. So I hope 3 examples was okay. We have more if you need them.
Yes, thank you very much. And I'm sure you have lots more. Jackie, can we go to you now, please?
Thank you. Well, perhaps I'll just say a bit more about our helpline. So we don't have programmes which are just for men, but we have a lot of men who use our services and engage with us. So if you think about Samaritans, and we have an extraordinarily number of volunteers across the whole country, many of whom are men. And actually volunteering with Samaritans, people tell us that it gives them a real sense of purpose, it gives them a real sense of giving something back, it's fostering really great connections across that Samaritans community. So that's kind of one really positive aspect that we often don't think about. We often think about the callers to Samaritans and the contacts that we have, but actually volunteering as well is a really great way to improve people's mental health. For our callers, as I think I already mentioned, nearly half of the calls we get are from men, and they're talking to us about their mental health, they're talking to us about family and relationship issues, about loneliness and isolation, a whole range of things. And what we are providing is this confidential, anonymous space where actually people can talk to us perhaps about things that they've never managed to articulate to anybody else. And it might be the first time that they've managed to tell someone how they're feeling, how they're really feeling. And actually through that conversation with a trained volunteer, it might help them then take the next step to tell somebody else, perhaps tell a trusted friend, a trusted family member, and then seek some help beyond that call from us. So, and an evaluation of our helpline showed that we did see positive outcomes, not just from the call itself, but also a week after that those positive outcomes were still there. As well as our helpline, we do a whole range of different programmes. We talked a little bit about the work we do with Wales, so I won't talk about that again, but thinking about some of those more kind of male-specific areas, we do a lot of work in prisons. So we train prisoners to provide emotional support to their peers, and that's in a scheme that we call the Listener Scheme. And of course, the vast majority of the prison estate is male prisoners. And again, what we find is that obviously that's providing really important emotional support to people in prison, but it's also giving listeners, the prisoners that we are training, they go through training and they graduate, they get a certificate, and what some of those young men and indeed older men are telling us, it might be the first time in their lives they've ever got a certificate. The first time their families get to come to that graduation ceremony. And you should see, honestly, I've been to them, and they were just incredible. The the kind of look of pride that they have of being like, I've got the certificate, I've really achieved this thing whilst in prison. It's just incredible. So again, it's not just the impact that we're having on our callers, it's also the impact that we're having on people who are training with us to be volunteers, I say, in lots of different ways, including within prisons. And then we also do a set of work with veterans and the armed forces. So we have resources and a dedicated helpline for veterans and members of the armed forces as well. So it's a range of programmes in there. The final one perhaps I'll mention is just around workplace training, because we have mentioned training a bit during the course of today's conversation. And of course there are a lot of male-dominated industries. And so we've done a lot of work, for example, with the construction industry. We've done training with fire services, with police. I think we've delivered something like, my notes tell me, 550 training courses to over 100 organisations across the private and public sector in the last year. So again, really building awareness, building confidence in these male-dominated spaces, which can really kind of change culture, as well as then all those individual skills around talking about it. So really important space, we think, in terms of what can be done in London, where there has been some training done already, is really building on that and working with employers, working with actually the private sector to really get that message across.
Can I ask you, Jackie, very specifically, obviously your organisation and your volunteers speak to so many different people over a year. Are there issues that come up and learning that you take from the people who use your services that you have passed on to organisations and policymakers?
Yeah, I mean, that's literally part of my job. So it's a great question. So we, it's really important, isn't it, that for Samaritans, our helpline, the services we provide are really, really critical to preventing suicide. But also, we can't do this alone. And actually, all the drivers of suicide that we talked about right in the beginning, we have to address those things. And so what we're trying to do is use evidence from our own services, but also lots of other services. So Shout have some great evidence, for example. James's Place that Amy mentioned, Mind will have it as well. And make sure that what we are doing is bringing the issues that people are talking to us about and absolutely drawing attention to those issues by policymakers, but also working with people with lived experience to then think about what are the solutions to that. So not just taking the issues, but actually doing a whole set of work to then come up with a series of recommendations around where we think there can be change. So yeah, that's really important that we learn from the things that people are telling us.
Thank you. And David and Simon, have you decided who's going to answer these questions, or are you both going to do this?
Well, I can make a start. I'm sure he can add in. I mean, I'm really glad actually that Jackie mentioned lived experience, because mine services throughout London, lived experience is embedded in our service delivery. So we work with people who have experience of mental health, and they're trained and supported to work with people who are newly diagnosed or who are struggling. So we've got a variety of mentoring schemes, whether that's intergenerational or veterans, for example, is another group that we work with. And these have proved to be really positive in terms of engaging with residents. And we use a variety of outcome measures. So we use WebWEMS and the Recovery Star to highlight outcomes. But also what we do is we do a lot of research, narrative research, with people who are engaging in our services. And we exhibit these findings. So we highlight the findings in order to generate awareness and improve knowledge and improve engagement. And there's just a variety of peer support initiatives throughout the London Mind network. The Barbers Project, which Simon has specifically spoken about before, but there's a lot of engagement through men's talking groups. We have used the medium of music to engage and offer a space for people to come together. We also have a digital hub, a men's digital hub, where people who are digitally excluded, whether that's through poverty or perhaps lack of space, can come in and get support to be able to engage with activities online. We do a lot of work around eco spaces throughout the network, so gardening groups, to look at nature and to explore nature and to use that as an opportunity for dialogue to emerge. And also our work in schools through intergenerational projects, and of course our work with the University of Kent and Greenwich University, providing peer support to engage with students. So there's a variety of mechanisms throughout the network, and I think the important thing there is to learn from the experience and to be able to highlight the positives of peer support and lived experience. Did you want to add anything?
Just to give you a tiny little detail, a practical detail about how projects can sort of be taken forward and how it evolves and how that can make an impact in terms of data that you get. So, for example, the barbershop project, you're dealing with individuals who may have come forward and volunteered their time as a barber because perhaps a couple of years ago they lost a customer and it rocked them, and they may have cut that individual's hair that week, and they simply are struggling to understand what and why. So how do you, in an environment which is piecework, they're paid when they cut hair, when they spend more time chatting, how they're losing money, how do you engage and support and encourage somebody to be able to take that forward, so and get involved in a practical way with the project. So the magic formula for that particular project was a 35mm sticker that is eye level on the salon mirror that says your barber can talk to you about well-being, and it's got the URL on. And for some men who are still concerned about stigma, they might not say anything, they might not engage with the barber, but they'll clock the information and they'll contact us later in the privacy of when they're on their own. There's information leaflets around as well, which again we've got statistics on how many of those leaflets are taken by men when nobody's looking, because again we're still worried about stigma as individuals. But then there's a large chunk of individuals who will happily engage with the barber, and it acts as a conversational prompt, because when you've got barbers who are really enthusiastic about acting as an ambassador, a champion of well-being, there's only so many times that they're going to bore themselves to death if they keep saying, oh, how are you doing, sir, and all the rest of it, in terms of trying to have a proper conversation about well-being in the limited time they've got them in the chair. So the sticker has been the sort of the magic bullet, as it were, in terms of acting as that conversational prompt. To a great deal of the time, the customer will refer to it and say, there's maybe no other written material around. What's that? And it will prompt the conversation. But we've also introduced, so trying to almost mandate that as a key, not an optional, as we did in the pilot, but if you're going to be doing this seriously for the second iteration of the barbershop project, that you have to have the sticker if you're going to do this. Has had a significant impact in terms of numbers of conversations recorded, and therefore it filtering through to us for our crisis cafe and services and how many people are coming through to us. But the other element that we've introduced now is the Save One Life a Day. And often I'll get barbers coming to the training who will say, if I could save one life, I'd feel my involvement in this is worth it. And volunteers across all of our organisations will echo those sorts of statements as sort of classic human behaviour in terms of why we get involved as volunteers. So what we've introduced now in terms of being able to put an expectation in terms of how many proactive conversations a barber should be having. They're reactive in terms of the demeanour of the customer, they're reactive in terms of the queries and questions about the branded merchandise such as the sticker, but being proactive to say to them, first cut of the day, you've just had your morning coffee, you've come out onto the floor, you're about to cut somebody's hair, I want you to be proactive, and for that one conversation of the day, I want you to say, well, have you seen this, and again, it helps to put some context in it in a way that doesn't overburden them, but still allows somebody who is being paid for every second is valuable, paid by piecework, to be able to feel that they're making a real difference. So it's practical things like that, and we've seen an 8-fold increase in the number of conversations from the pilot to this latest version of the project, simply because of these little practicalities. So just thought that would be. You get a lot of top-level data, and I think sometimes it's little details can be quite useful and interesting as well.
That's really interesting,
Sorry,
really helpful.
Marina, just Amy's got her hand up, I think.
Sorry, I'll come to Amy in just a moment, but thank you, Chair, for showing me that. Simon, what I would like to ask you, you've just said that the sticker is very key to this project. Is the sticker and the wording only in English, or do you have other languages as well?
That's an excellent question. So far, it's been English only, but that's a really good point. The issue would be is that even with one sticker, there is sometimes resistance in terms of that being used and that actually being applied. Sometimes that can be a bit of a deal breaker for us in our conversations with the barber. So the idea of that there's going to be a range of stickers, or I suppose the answer would be we don't have a sticker in English, we have it in whatever the barber thinks is the predominant language for their customer base. That would be the answer if quantity of stickers became an issue. But that's a really good point, and it's something I will investigate with my barbers. Thank you.
Thank you. Sorry, Amy, you had your hand up.
No, sorry, and it links quite well, actually. I just wanted to mention one more programme. They were in the office last week, and I'll be in trouble if I don't, but it links into the need for culturally sensitive programmes and understanding that, stigma is different in different communities. We have a programme called Chai in the City, which is around getting South Asian men to talk as part of their community group. Traditionally a population where the stigma of men's health is prevalent and the idea of masculinity is very different. So again, a grassroots programme. What I would say about all of these programmes is there's an incredible amount of great work being done, both from large organisations, but lots of small organisations as well, that, your question was around, give us the evidence. And for a lot of the work, we do have evidence of what works. But there is also a lot of programmes that aren't evidenced yet, because they are good people doing voluntary walking, talking groups or barbershop groups that don't have the funds and the resources to measure the impact that they're having on their cohort, their community, and then aren't able to apply for funding and scale that up. It's something we're working on, but I think if you're looking at an overarching London approach to men's mental health, being able to give those local groups the resources to measure their impact and argue their case, I think is really important, because those examples, and there's many that we could talk to, know they're doing good work, but they don't maybe have the evidence base that they could bring to a kind of assembly meeting like this today.
Right, thank you very much. My next question is listed to ask particularly David and Jackie, but if any of you do want to jump in here, it is about the service provision from the NHS. So what I'd like to ask you is, to what extent is the provision of NHS-run mental health services meeting demand in London, and how can the voluntary sector complement those services? So perhaps we could start with Jackie then, please.
Thank you. I think we all know that there is a massive issue with waiting lists in terms of access to services. And I think the voluntary sector is already complementing, if not propping up, perhaps the NHS in this space. So just talking from Samaritan's experience, over the last kind of 18 months or so, over 330,000 callers told Samaritans that they use NHS mental health services, and that number's increasing. What we're seeing is that those callers are more likely to explore and express suicidal feelings in their calls when they talk to us. They're twice as likely to talk about self-harm, and they're more likely to contact us at night when lots of other services are shut. So we take 3.3 million calls a year. that's the numbers I've just talked about. That means 8% of all of our calls we received were from someone who told us they used NHS mental health services, but we don't get any government funding for our helpline at the moment. So we are providing this service to support not just the NHS, but also all of those people who aren't using NHS services. And what we hope is that, you know, they're talking to us, but then they are also, we're only one part of the system, right, across the suicide prevention landscape. We as Samaritans, but also lots of other voluntary sector organisations, and then all those statutory services. Like, what we want are better partnerships, better collaboration, but also recognising that we're having to raise every single penny that it costs us to deliver that service. And that's really challenging. And frankly, it's getting more challenging as well with cost of living, costs are going up, and funding. You know, there used to be funding specifically for suicide prevention from national government, and that has all finished as well. So it's a real challenge at the moment, where voluntary sector are absolutely providing critical services as part of that landscape, sitting alongside the NHS, but having to raise every penny of that to deliver them ourselves.
Thank you. David?
I mean, I don't think there's a secret in that, you know, the NHS is struggling to meet the demand for mental health support in London. And I think it's worsened since COVID, and I think there's a lot of issues related to COVID, particularly for young people, issues around isolation, loneliness, increased anxiety, which we're now seeing in the mental health system. I think there's also been an increase in complexity at a primary care level. So what would have been deemed suitable for secondary care probably 5 years ago is now part of the primary care mental health services, which brings challenges itself. I think there's huge demands in terms of recruitment and engagement of the workforce. And I know certainly in South East London, there's been a big drive to recruit staff, and it's been met with lots and lots of challenges, which then of course impacts on the demand and waiting lists, etc. I think the voluntary sector, as Jackie said, is a significant player, I think, in terms of mental health support in the system. And there's lots of, I think it's really important to acknowledge the point that Amy made about very small community grassroots organisation, I think basically keep the NHS afloat in terms of the brilliant work that they're doing in localised communities, which often goes unheard. There are examples of really good practice happening. I can talk about South East London, where Mind are collaborating with Oxley's on an integrated pathway, so that individuals will have a seamless service and be able to access a load of preventative support from the Mind network. And that's proving to be very successful. And it's also engaging GPs and primary care, so that we're also looking at physical health, which again I think is a crucial issue. And certainly in London, there's an abundance of crisis cafes and crisis hubs that are run by the voluntary sector, which have proved to be very successful, and stopping people from accessing A&E and expensive secondary care. But the demand is rising, and I think we need to be investing more in the voluntary sector and in prevention in order to meet the need.
Thank you. And sadly, having worked in the charity sector for various health organisations, it is an ongoing issue and has been for decades. Is there anybody else who might want to come in on that final question from me? No? Yes? Sorry, I can't, forgive me, I can't see.
I was just going to, I mentioned just that earlier, and I think it supports what we're saying about the need for more investment in the system. 80 is from the University of Manchester in 2021, 82% of men aged 40 to 54 who died by suicide in 2017 were in contact with primary care services prior to their death, and half of those men were in contact with mental health services. So I think it's always a stat that sticks with me when we're asking if the healthcare system is responsive enough to men, and when we're consistently talking about, oh, the problem is just men don't seek help. Those men had sought help, and I think they were failed by the system. Thank you.
Thank you.
Thanks.
Thank you, Chair.
Thank you. Thanks, Amy. Jackie, if I could come back to you quickly, you spoke about the strain of resources on Samaritans, and I just wanted to ask about the effect of the national insurance rise and the effect that's had for you as a charity.
Yeah, I mean, it has directly increased our costs significantly. So we have a relatively small staff base compared to how many volunteers we have. So we have over 20,000 volunteers. But still, our staff base is important in order to support those volunteers. And yes, our costs have gone up because of that, which has added to that financial challenge that we are now facing.
But will you be managing to retain all the staff members that you've had before?
We have experienced, I guess no, is the frank answer. It's a challenge that we've experienced with the rising costs over the last couple of years, and we continually have to look at how we can deliver our service and all the work that we do with increasing costs and reduced money. So yeah, we are always having to look at how we cut our cloth accordingly, which is challenging.
Thank you, Jackie. Assembly Member Wilson, did you want to come in?
Thank you, Chair. Jackie, in your introduction, you mentioned one of the contributing factors being sort of social isolation and loneliness. And just now, David, you the first sort of mention in this discussion about the impact of COVID. I would say it's not so much the impact of COVID, more the impact of lockdown as a policy response to COVID. So I'm just interested to hear if perhaps if you could expand further, or other panellists also wonder whether, certainly from a mental health perspective, was it a catastrophic mistake for government to forcibly break up so many people's social networks on pain of prosecution?
I can say a little bit about what we thought might happen around suicide, around COVID, and which actually didn't happen. That's helpful. So one of the things I think everybody was concerned about when the pandemic happened was that we might see rates rise. And actually that didn't happen. And that's a really important message. And I think there was a really interesting piece around community cohesion and people pulling together. And one of the things, I don't know about you, but one of the things I certainly noticed during the pandemic was everyone was checking in on each other in a way that perhaps wasn't happening quite so regularly. And so we saw this, you saw it online, wasn't the same, was it? But, you know, I work for Samaritans, so we like to check in on each other a lot, right? But, you know, every interaction, what we had was really asking people how they were okay first, people checking in on their neighbours. So there was this immense kind of community spirit. And, I mean, I don't know why rates didn't go up in the way that we thought they might, but certainly that was a real, we think that community cohesion and that community connection was an important part of that.
I mean, I think actually it's quite interesting because I've literally just written a paper on this. I think for the first 6 months to 12 months, we found, certainly in Bexley, increased resilience that we were quite surprised. So people who were vulnerable, who were in contact with secondary care, were finding mechanisms to engage, whether that's digitally or, as you said, through community mechanisms and that support. So we were quite surprised with that. However, long term, I think we've definitely found increased anxiety, people who are neurodivergent, and people who were probably in that sort of 13 to 15 age group who were isolated from school and education. I think the impact of that, we're starting to see that definitely now with, you know, rising waiting lists for CAMHS, and the people who are engaging with us through Mind, they cite that factor, you know, the lack of engagement with their peers through school, and also the challenges, of course, of homeschooling and education attainment. So I think there's multiple factors there. Whether it was a mistake or not, who am I? I mean, it's hard to say. I think if we needed to have a lockdown again, it would be interesting to see how many people would comply.
Oh, thank you, Dave. And I think we look forward to reading your paper then as well. So, thanks. Assembly Member Harani.
Thank you, Chair. And just a further question to all on the panel today, just on the Mayor and what you see as the Mayor's role in supporting men's mental health in London, and what action you'd like him to take further. So maybe start with Simon on my left.
I suppose it's just that high visibility in terms of acting as a champion, a visible champion of this as a topic and of the sector in general. So I suppose when it comes to civic visits, more visits to what's going on at the coalface would be enormously useful. But then there's also that leadership role, isn't it, in terms of acting as a champion in terms of the funding that's needed, and whether trying to pull together private sector alongside state funding to create specific pots that could be used. So, he's in a privileged position in order to act as that catalyst to bring ideas and money together. That would be super.
Dr. Palmer.
Yeah, similarly, really, I think to be a figurehead and to help normalise conversations about mental health. And I think acknowledge the work of grassroots community organisations and the voluntary sector, and to advocate for them in political circles, and to look at funding for preventative measures, and like what we talked about with men's specific spaces and innovation, which are challenging to measure and challenging in terms of outcomes, but I think it needs to be a long-term approach, to look at a 5 to 10 year plan.
Okay. And Jackie, I'm going to ask you to, because you referred to a programme which the Mayor supported, Thrive London, I think, in one of your earlier remarks. So if you could also answer the question, but also any experiences you have of Thrive as well.
Thanks. Yeah, I mean, Thrive London was a programme that was really kind of looking across the region and had some very specific suicide prevention initiatives within it, which were really brilliant and continue to be great. So, for example, looking at real-time data around not just suspected suicide, but also self-harm presentations at hospitals, so providing a really strong and important evidence base around what's going on in London in a real-time way. So, yeah, we'd like, I suppose, 3 things from the Mayor. We'd like funding to continue around those initiatives. It's not surprising that we're asking for that. But also, and we've heard it already, working with the voluntary sector, both kind of those national organisations like us, but also those local community organisations where they're supporting men's mental health, and what they need is funding visibility as well, particularly around some of those high-risk groups that we talked about. We also think the Mayor has a really interesting role to play with employers and the private sector, where he can really galvanise action and encourage London businesses, especially in those male-dominated sectors, to adopt mental health strategies, including kind of suicide prevention and awareness training. And then our third thing, I mean, wouldn't it be amazing if London could be the region that said it would deliver suicide prevention training to all frontline workers? I mean, it's ambitious, but wouldn't that be incredible to have that as a target? So we think it should be, suicide prevention training should be made standard for all frontline workers. We've heard a lot today about people in contact with the system. Like, we want every contact to count. And we think you've got real opportunities working across, London Fire Brigade, Ambulance Service, Metropolitan Police, but also kind of job centres, all of those different spaces that people are in. So, yeah, we'd love to see you get a commitment to training frontline workers across London, embedding mental health priorities and training across the city, and including through the transport network as well, which we've talked about.
Thank you. And I'm glad you mentioned employers as well, because there is a good work standard, so it would be interesting to see how that can be picked up, maybe something the committee can take up after this meeting. And Amy as well, same question, but also I think we've spoken about Andrew Tate earlier, but also about the mayor having his own platform, and he's also recently spoken out about his mental health struggles as well, and just sort of the importance of how he can use that platform as well to present a counter narrative.
Yeah, most definitely. I think we've heard so many examples today of the different challenges that are facing men and a real range of solutions, whether that be alternative content to Andrew Tate, to barbershops, men's sheds, clinical training for professionals, frontline workers. What we would love to see the mayor do is take a leadership position on a men's health strategy for London and bring this work together. And you know, Dr. Palmer mentioned it as well, the connection between physical and mental health. Today we're talking about mental health, of course, but we know men are also falling behind in physical health rates with higher rates of premature mortality, preventable deaths in men due to, you know, cardiovascular disease, diabetes. Undersits this is our approach to gender norms and the cultural context in which men sit in. I would love to see a consideration of a full men's health strategy that looks at both mental and physical health. We know when men are in good physical shape, that helps with their mental health and vice versa. And for the mayor to take a leadership position of that. And I think now is the perfect opportunity because we have the National Men's Health Strategy coming. Huge amounts of work are being done by the Department of Health. There's evidence base there. How can that be tailored and localised? What can we learn from that for London men who are a different cohort to men? And I will advocate very quickly for other areas of the UK, where we know that Wigan, Leeds, York are also looking at local men's mental health strategies. What can we kind of learn from the other mayors in these areas to take a really kind of strategic, overarching approach instead of this becoming maybe a little bit of piecemeal work?
Okay, thank you.
David, did you want to?
Is it possible just to add one other thing, actually? And it relates to physical health. It's really important to recognise that people on the SMI register are more likely to die 20 years earlier than the general population. I mean, that's a shocking statistic. So that's something I would definitely advocate for the mayor, adding that to the list and to the strategy, and to recognise the poor physical health outcomes of this particular group.
Sure. Could you just clarify SMI register?
Sorry, severe mental illness. Thank you.
Thank you. I just wanted to ask one final question on that about the TfL estate and advertising. I think, Amy, especially, I've seen Movember ads go around that time of year. I'm guessing those are paid for? You don't get any free spaces currently, or you do?
That's a question I can come back to you on from Adam in our marketing team. I know there is some allocated spend, but we also have really generous partners who donate space to us as well. But I can come back in writing with
Okay. If you could come back in writing for us, if TfL is not one of those partners donating space, would it be presumptuous to suggest that you might like to have space donated?
I think, speaking on behalf of marketing colleagues, I would say yes.
Yeah, okay.
But again, I'm speaking out of my comfort zone slightly there.
Okay, thank you.
Thank you, though.
Assembly Member Wilson.
So my final question, Amy, you've actually already started to answer it in your answer to the previous question about the government bringing forward men's health strategy, so overall men's health, looking obviously balance physical health, mental health within that. So just kind of relatively quickly, perhaps starting with you, Amy, but then others as well, any sort of particular items relating to mental health that really should be kind of prioritised within that wider overall men's health strategy, please?
Yeah, the simplest way we can think of it, and I would give a quick analogy of a few people that have been trying to understand why we need a men's health strategy. The data for men's health across physical and mental health, is there. And a quote that has always stuck with me is, if all of the fish in the pond were dying too soon, you wouldn't look at the fish, you'd look at the water. And that is exactly what we're trying to do through the men's health strategy. We're looking at the systems and the gender norms in which men are living and working that are impacting their mental and physical health. The simplest way to think about what we're looking for a strategy to do is to reach men, and that's going to where men go, using the language that we know, increasing their health literacy, increasing uptake of NHS health checks, for example, reaching men responding to their needs. So, you know, a lot of work and time goes into getting men to turn up for healthcare services or look after their health when they do need professional help, making sure that health is responsive and men aren't going through all those barriers, turning up, having a poor experience and never coming back. And then how are we retaining men in positive health as well? So we would advocate for a local strategy to look at how it responds and retains men in good health.
Yeah, I mean, absolutely. And I think what we really want to see in the men's health strategy is suicide prevention. Sounds obvious, but there's a lot of issues, aren't there? So we definitely want to see a commitment to preventing suicide within there. And we'd like this commitment to this no wrong door approach, whereby men in contact with the health system, doesn't matter which bit of the system they're in contact with, they are getting the support that they need through that first door and then kind of being moved through.
Yeah, no, I concur with that, and just possibly add in about lived experience, acknowledge and engage lived experience in the whole process, because we've talked today about a variety of initiatives which have proved to be very positive for engagement, and also involve the voluntary sector in the strategy, and if possible, grassroots communities as well.
Yeah, I think the voluntary sector is just too often ignored, and even with our own, we were involved professionally in supporting GPs in the Bexley area for a physical health initiative. GP practices in Bexley weren't hitting, or right across South East London, weren't hitting their target in terms of the number of physical health checks that had to be undertaken for patients on the serious mental health register, and so we were brought in just to give a different perspective and to, I suppose, train and support those frontline GP staff in how to engage with patients better, because all sorts of barriers get in the way. But even when you were looking at the evaluation and everything, we made a huge difference. But there is still so much of a focus of the NHS on what the NHS delivers. It's where we're often, the afterthought at every stage of the game, and we're cheaper, and I'd say we're just as good, if not better. I took a grandson to A&E, scraped knee, and there was a triage nurse there who was shooing away a 20-year-old lad because he had mental health issues. Oh, you can see the queue. Even in this modern age, you'd have thought the health professionals, now whether that's a minority or not, I don't know, but it just brings home that we've still got a long way to go. And an individual, you shouldn't have to, when the voluntary sector are delivering, A&E for mental health effectively through our crisis cafes, that you can drop in and without an appointment, every evening of the year, including Christmas Day, you can walk into our crisis cafe and a plethora number of others delivered by the voluntary sector, and you'll get exactly the support you need. Whereas A&E sometimes is a lottery still, and they don't want you there anyway because they've got they've got so much to deal with. So I think it's just use the voluntary sector more.
Thank you, and that concludes our first panel for today. So can I thank you all for attending and answering those questions? We really appreciate the time you've given up to be with us this afternoon. We're going to take a 5-minute break here to come back for our second panel. So I'll adjourn the meeting now and hopefully see you all back here at 3:43. Thanks. Thank you all. to the Health Committee, and big welcome to our second panel of guests. Thank you so much for joining us. Sorry, some of the committee got waylaid talking about their barbershop habits after the first discussion, so I think everyone is arriving back now slowly. So can I welcome Dr. Luke Sullivan, clinical psychologist and director, Men's Mind Matter, Lucas Whitehead, head of marketing and partnerships from Andy's Man Club, Sam Davies, founder, Men Who Talk, and Mark Rowland, Chief Executive Officer from the Mental Health Foundation. So a big welcome and thank you all for joining us this afternoon. Sorry, it's perhaps slightly later than first billed. Could I start with coming to all the panel, and I'll start with you, Luke, if that's okay, to ask what distinct mental health challenges do men face?
I think the problems and challenges that men face in terms of health and health inequalities are quite widely documented already. So, for example, Untold Problems, produced by the Men's Health Forum many years ago, lays out a number of factors that are really important. And the more recent one, Lost Boys, from the Centre of Social Justice, speaks quite eloquently on a lot of the issues faced by men and boys. I think those issues are pretty similar across the country, that there are broad issues that are gender-specific to men. But within London, London's obviously a very different place. It's very diverse. What the population looks like in Lambeth, for example, where I've worked as a clinical psychologist in crisis teams for many years, is different to what it looked like in Enfield when I worked much further, much closer to the outskirts. That the populations are very different, the needs are very different, and therefore the challenges are very different when you go from borough to borough. But the broader issues are pretty similar across the board. At Men's Mind Matter, our focus is on suicide. And suicide for us is the most glaring health inequality that exists. It's the one that has been left to and given very little attention until more recently. So when I first started out looking at men's issues in 2004, I was asked to go and do some research for South London Maudsley NHS Trust, looking at the state of men's mental health in the borough. And I really wanted to find some really interesting things, and I couldn't. I couldn't find any services for men. I couldn't find any people that were thinking around men's issues. There was very little apart from what we know are services that men access more predominantly, for example, the criminal justice pathway. But in terms of mental health services for men, there was nothing. There was no research looking at men. And it dawned on me a couple of years after doing that research that the most important finding was that there was nothing. There's a real neglect to think about the psychological experiences of men and boys, the health issues that they faced, and then a need to do so. So thinking around the health inequalities or the inequalities that men and boys face, their unique experience, is a relatively new thing. We haven't really done it before, so we're in our infancy. But for us, at Men's Mind Matter, the one that we wanted to focus on first, and the thing that we think we can bring the most value to, is around addressing suicides for men, but not just for men, for all people. There are other things, if you look across the board in terms of health outcomes, that men are more likely to die across all categories of death and injury across the age group earlier than women. It's a remarkable statistic. There are other things, of course, the high rates of men in prison populations, the homeless populations, the struggles that boys are having in education and the identity crisis that they're facing at the moment. The list goes on. So it's really lovely to be here and to be able to think with you all about these issues and what seem to be the priorities that we need to start paying attention to and how we can do that in a more gender-sensitive way. So thank you very much for the invitation.
Thanks, Luke. Lucas?
Check my microphone's working. There we go. Yes. Yeah, so obviously I come from Andy's Man Club, an organisation that is entirely non-clinical. We are completely anecdotal in our approach. We, take the feedback and the findings of men who come to our sessions and who speak openly about their issues, and that gives us perhaps a more personal insight into some of the issues that they face. I think that as a man in this country, or men for generations in this country, or in London, or wherever you are in the UK, you're brought up and you can be conditioned often to believe that if you do open up, if you talk about your problems, then ultimately you're a burden to those who you're opening up to. There's still, in a lot of elements of society, a very traditional attitude to the role of men in society. Men should be strong, they should be the breadwinner, they should show no emotion, they should be the people who are basically leading the charge for the family, and this is what ultimately is basically preventing men from opening up in greater numbers, I believe, across the country. For us as a charity now, we have close to 300 talking groups nationwide that are all attended by around 25 people on average. And the towns where we tend to have the most success are where we've been established for the longest time, where we have high deprivation, we have a lot of unemployment. We have, basically a post-industrial situation where the industry that's been in the town has left, and the people have sort of been left in a lurch. A lot of men don't know where the role quite fits in, and that's where our success has been greatest. And I think that for us, the difficulty that men are sort of facing is that they've lost that sense of community. A lot of men in some of those towns, in some of those cities, they still have that sort of they still have that feeling that if they open up, they're burdening people, that they're struggling to basically to open up, and it's just a difficult scenario that a lot of men find themselves in. Realistically, we want to, as a charity, reframe men displaying vulnerability as a show of strength. Ultimately, for men to open up, it's a very, very difficult thing to do. So we're hoping that by sharing our experiences and sharing our stories, that people hope to do the same. In terms of actual evidence and data, we don't actually take anything from our men whatsoever, and there's a very, very important reason behind that. We want to be a simple, effective service that just allows men to open up. We think that is difficult enough. That is something that men find increasingly difficult, despite the efforts of a lot of groups like ours and like obviously some of the groups on this panel, but that is the most significant thing for us, that men are finding it still increasingly difficult to open up about the issues they're going through.
Thanks, Lucas. Sam?
Yeah, thank you. I think further to the points that Lucas and Luke have made, at Men Who Talk, we talk a lot about the stigma that men face. I think in London, the issues that men face with their mental health and well-being are pretty similar to what they face nationally. Men from different cultural backgrounds, from upbringings, face huge kind of background-specific stigma, but also the general stigma that we see around men talking, men opening up, these kind of notions that men don't talk. And something that we're keen to do at Men Who Talk is to reframe, as Lucas has been saying, reframe the power of talking as a good thing, as a positive attribute for men, but to also look at the power of doing that at all stages. I think at the moment, one of the main challenges that men face with their mental health is that we're still, as a health system, we're still switched on so heavily to crisis intervention, to only ever seeing people when they reach crisis, to only being at that level. And despite our best efforts as teams to try and tackle that, when the whole health service only sees an open door at the last point of care, at the crisis point, we're perpetuating that stigma. We're helping to say it is good to talk, but only once you reach a certain level. And we need to collectively look at what kind of barrier to access that presents. When men, even the kind of notions of saying it's okay to not be okay, I personally have quite a big problem with that phrase, because it encourages men to see that it's okay to suffer. And whilst I know that that's a campaign that was tried to create an openness around talking about mental health and well-being, actually, we want to try and say, yes, it's okay to not feel okay, and everybody has balances and fluctuations in their mental health and well-being, but it's not okay to be on your own and to be suffering and waiting until you reach that crisis point. Reach out, talk, have mental health instead of just focusing on this crisis. So we talk a lot about stigma, cultural stigmas and barriers to access are some of the biggest challenges that we find at Men Who Talk in terms of men's mental health, both in London and nationally with our services.
Thank you, Mark.
Yeah, thank you very much. My name is Mark Rowland. I'm the Chief Executive of the Mental Health Foundation. Thank you for holding an evidence session on men's mental health, especially in one of the greatest cities in the world. I speak to you as the Chief Executive of a charity that is running some work in London schools, working with young boys and men on emotional formation, emotional regulation, identity. So we have an in-school counselling programme called Becoming a Man. So bringing that experience, we do a lot of research. We've just done a research study around men's mental health. But I also come as a brother who has lost a brother to suicide. And my brother Daniel was right in the crosshairs of men who are at the highest risk of poor mental health and of suicide. And so I've seen with my own eyes the deterioration and the combination of factors that can contribute to this concept of social defeat. And where you've got high levels of role uncertainty in terms of the male role model, the role in society, when you've got concerns about economic security, when you've got a mental health service which is too quick to dismiss or to underestimate the extent specifically of male distress, you get this underreaction, which we see a lot in families bereaved by suicide. People saying, we were banging on the door, we told you there was a problem, he told you there was a problem, there was a risk assessment, and yet not sufficient action was taken with enough urgency. So I come to you with that lived experience, and as a middle-aged man who is also trying to kind of work out how to manage my own mental health and finding it difficult at times. The picture nationally is not good in relation to mental ill health. There is a 20% increase in referrals to mental health services and in people being classified as disabled, and that gender split has increased for men and for women. But you have this strange picture where on the one hand you have people being diagnosed with anxiety. Roughly, if you're a man, you're 3 times less likely to have a diagnosis of anxiety. The same goes for eating disorders. You're 3 times less likely. We did a study during the pandemic which found that women reported to be struggling much more than men. So on the one hand, you have this picture that actually a gendered lens looks at how men appear to be doing better. And yet what appears to be happening is that men's distress is not fitting into the diagnostic or clinical definitions. The distress is being articulated and manifested in a way that is leading men to be either they've got 2 choices, and I'm not sure which is more dangerous. One is suppression of the feeling. Push it down, make sure nobody sees it, and make sure everyone thinks you're okay. Or 2, and sometimes it comes in after a few months of trying the first, it comes out in forms of behaviour that society deems as to be completely unacceptable, and then a punitive measure is then taken in dealing. So it's the same distress, but it is coming out. So we have a hypothesis that there is a really significant underdiagnosis of not necessarily conditions, mental health conditions, but the level of distress that men are reporting that is being captured by the system versus women. But as my other panel members said, you know, men are much more likely to be experiencing violence, 90% of the prison population is male, 87% of rough sleepers are male, education outcomes are falling for young boys. And then you've got this massive standout around suicide rates. And I was just at the National Suicide Strategy Advisory Group last week, and we got the latest numbers for 2024. 5,690 suicides registered in England last year. About 11 suicides per 100,000. Now, of those, 74% of them were male. And men are being much more successful. And as my panel members mentioned, this message about prevention has a disproportionate importance for men because they are waiting longer. So men are disproportionately affected by suicide. But in London, it is actually the safest place in the country in terms of suicide. So suicide rates are about half in London as they are in North West and North East. So there is some good news that the context of London, and because men are so disproportionately represented in the suicide rates, that is better for the men of London. We've got to do much more research to understand what those factors are that are keeping men safer in London. But it does show this, that we cannot wash our hands and conclude that the experience of men is... my message is it's fundamentally malleable. The quality of our inner lives can be changed, it can be affected. There are factors that can be addressed, and there's something that's happening in London that we can learn from, whether it's the rich cultural heritage that binds people together in London, whether it's the proximity of people living together, or whether or not it's rates or degree of religious affiliation. We're not sure, but we know that there are lessons that can be taken for positive from London, as well as some of the challenges and barriers, which I'm sure we'll go on to in terms of where men are being missed and opportunities to care being completely lost.
Thank you, Mark. Just coming back, and many of you have already mentioned the barriers, lack of services, stigma, services not being apparent until the crisis point, and the difficulty in diagnosing. Is there anything further you would say about the barriers or ways to overcome them? Okay, anyone? Yes, no.
Yeah, I think a big point with the barriers to access is not just the structural issues of not necessarily having available services. We talk a lot about the fact that we have lots of great campaigns, but very little structure behind those campaigns. So when we're saying Men Get Talking and, you know, ITV did their Time to Talk and Britain Get Talking and all of those things, do we then actually have the mental health services for them to go to? And men regularly say to us in our services, no. They go to see these campaigns, they go to put themselves forward for NHS services, for other services, and they get bumped onto a waiting list. And their problem is not something that can be sat on a waiting list for 3 months. It's something they want to talk about now. And we have a very short window to engage men. And, you know, Lucas mentioned about the fact that Andy's Man Club have worked really hard to create an environment that is just incredibly easy to access, and that's really important. We believe in you've got that one snapshot, that one moment, so you need to make the most of it, because that could influence how men engage for the next 5, 10, 20 years. The other element of barrier that hasn't necessarily been touched on yet is the educational element of encouraging and helping men to know what's available, so having an awareness of what is around, but then also actually how to access the services, how to engage with them. We find lots of men come to Men Who Talk, not necessarily always understanding the services that are available, and sometimes they want to actually talk about how do they get into counselling? How have other people managed to get it? Is it a referral process? Do they have to go through their GP? And whilst these things are being improved, it's still a significant barrier when a huge proportion of men are coming and saying to us, we don't actually know how to access these services in the first place. We don't know how to find them. We don't know how to access them. then once they do access them, we have, as has already been mentioned, we have all these other barriers that play in. But this educational piece, and it's great to hear, the Mental Health Foundation doing lots of work in schools, because that's a key area. We'll never address this problem until this is something that we talk about at the earliest ages and give everybody the confidence in knowing how to talk openly about mental health, but then also how to access different services, so they're not going to A&E when they're experiencing minor symptoms of depression or anxiety. They're able to access a community group instead, which then helps us provide much more relevant resourced programs, and also helps to avoid people just constantly feeling, and men particularly, that they have to be in crisis in order to access support. Because we're here, we run services that do exist, we try and talk about them as much as possible, but there's always more advertising and more campaigns that we wish we could run. But actually building that awareness of who we are and what we do, that's a really important thing, and that's a barrier that we have to address if we're going to make a meaningful change, I think.
Yeah, I think one of the things with mental health services is that we still don't have a holistic approach to how people come into services, and it means that if you come into, or you're struggling with addiction or homelessness, or if you've got a history of being violent or abusive, these are difficult issues. They disproportionately affect men, but they are often are a barrier to men being able to access mental health services. So it's a completely different pathway if you are dealing with addiction than dealing with the underlying mental health issue. And until you can integrate those two, it has a disproportionate impact for men getting person-centred, therapeutic, healing-focused support rather than the punitive measures. We did a research study recently, and we found that the level of distrust in services for men is still really, really high, that these stereotypes persist around violence and toxicity of men. I think there is a real issue, because you have an imbalance between the gender of the mental health services. Take talking therapies. Talking therapies are 73% women. And there is a legitimate concern as for women in talking therapies in terms of their level of safety when they're dealing with complex needs of men who have gone through trauma. But the actual ability for an opportunity for men to face and meet another man in that, and that's probably not surprising that only 32% of people accessing talking therapies, which has been the biggest revolution in mental health care over the last 20 years. It's world-leading, increasing access to talking therapies programme. But it's something that has disproportionately met women's psychological needs. And it's not something that I understand is being actively addressed, to say, well, if we've got a groundbreaking new intervention that's helping and actually it's the best evidence programme we have on mental health, but it's not reaching men. And the workforce is disproportionately female. That's a systemic issue that London could tackle and could say, we're going to address that issue and we're going to take a real focus in addressing that inequality, either by developing male-centred interventions of a different nature, or by increasing the workforce that look like the population that need that help.
I think education's vital as well to this point. I think that for a lot of men, I think they look at the services that are out there and they assume that they're only there to basically aid people who've got diagnosed mental health conditions. I think from our perspective, a lot of the men who come through our doors, they're dealing with difficult circumstances in life, which then lead to mental ill health. We hear constantly, when we've encouraged guys to go to the GP to access public services, they almost feel as though they don't need it, even though they're very nearly at that breaking point where talking's, a very, very painful thing for them to do. I think that there is this sort of perception from a lot of men that those services are only there for when you do actually get to that crisis point and you are feeling as though you do want to take your own life. And that early stage prevention is what, you know, public services can basically offer. I think from our perspective, like we've sort of touched upon already, we're a simple service for a reason. Everything's built off shared experience. I think there is a perception from a lot of men that if they access psychological help or if they go to, you know, medical professionals, they're going to be met by somebody who, you know, respectfully might have just come out of university with a raft of qualifications, who doesn't have the requisite life experience that they actually possess. And that's the perception that a lot of men have of these public services, that, you know, it's going to be, to use a really unfortunate turn of phrase, it's going to be a shrink, you know, like from film or from TV that you see, when in actual fact it's going to be somebody who potentially does have that shared life experience, who can help you on your way. I think from our perspective, the greatest advantage of our group is that by encouraging people to talk at that early stage, it then encourages people to access those services and to access those mental health services. I mean, for myself personally, before my involvement with this charity, I wouldn't have dreamt of accessing counselling or therapy or any of those sort of services. But talking about my issues and actually opening up and, you know, realising that there were solutions to the problems that I faced, then led me to find other solutions. So I think, you know, like the points that we've made, talking therapies are really positive, and they can almost open the door to accessing those services and removing that distrust. Because, I mean, our groups, for every one person who's been because they've found an issue with a service that's been on offer to them, there's another person who's then been to another service and helped to dispel some of those fears that other people have around them as well at the same time.
Come in there. Yeah.
Is that okay? I'll just say a few words. I am a clinician. I have been a clinical psychologist for a long time now, 15 years qualified, but before that working psychologically in many ways, primarily in acute care services, so inpatient services, crisis resolution, home treatment teams being the NHS service that is tasked with providing interventions to people that are actively suicidal. During that time, I've met with people face-to-face who are at the point of not just having thoughts, but intentions and plans to end their own lives. I'm quite rare. You wouldn't find a psychologist who's been in crisis services for as long as I have, I don't think. And that experience is what I bring to Men's Minds Matter, because what I noticed in the home treatment team is, as a very limited resource, I could only see about 8% of the population within that home treatment team. I mean, 92% of people weren't getting access to any psychological intervention within that service because the resource is so limited. But what I did realise is that I had a unique way of working with people that were actively suicidal, and that in order to get that intervention out to more people, I needed a platform, of which Men's Minds Matter is that platform, to try to bring evidence-based psychological practices that are sensitive to the experience of suicidality, thinking, thoughts, plans and intents, to understand the mechanisms and then develop an intervention that could target those mechanisms to lead to a resolution. Men's Minds Matter is that platform, and using digital ways of working is a way of kind of bringing self-help, guided self-help, informed, supported self-help, and then interventions with a psychologist within a setting that's easily accessible at the point where it's needed. Now, in terms of barriers to accessing the services, the problem with suicide is, yes, prevention is great and we want to try to prevent people to getting to that point, but we're not at that point. So there are people that are actively suicidal in crisis that need help at that moment in time. You can't have a delay. If you delay, people will die, and they do. That's why we have such high rates of suicide. So you need something instantaneous that people can access, that's readily available, and that is accessible in a way where it doesn't necessarily leave people to waiting for long times or to feel too exposed and to feel vulnerable through the expression that they're struggling, which I think men are very sensitive to. So Men's Minds, you have to think very creatively about how you break down the barriers to men, because they are very different to those barriers that women experience when accessing services. We know a little bit about that. We don't know everything about why men struggle to access services. Some things are quite practical, i.e. historically men being maybe the predominantly breadwinners didn't necessarily have the time to attend the GP surgery. really practical, simple kind of observation about structural kind of ways that we used to organise ourselves, primarily with men going to work, women staying at home, which of course isn't the case anymore. There are other issues around whether or not those services feel the right services for men. So a lot of people who take their own lives don't have identifiable mental illnesses. There's a reason for that, which I'll touch on at another point. What they also don't have, they wouldn't also identify as having a mental health problem. That those services aren't the services where people are going to look because they don't identify with the model that kind of conceptualises their struggle, which I think is better conceptualised in the way that Mark thought about it or explained it as a psychological distress, not necessarily a mental illness per se. The model itself for mental illness isn't helpful when thinking about suicide. But the reason why people take their own lives is because something's happened in their life. There's a crisis that's impacted on them psychologically to the point where they're so distressed that they'll do anything to get away from that distress. If you understand that, you can design services that are a little bit more accessible and probably a little bit more attractive to the people who are experiencing the problem that they're experiencing. The other issue that I want to raise is, yes, it's good to talk, but who are you talking to? That whole campaign is built on the idea that if you do stand up and you do take that risk that I'm going to say something, that there'll be somebody there to help you. Now, I've been doing this work for a long time, and I knew that when people open that door and look for something, there's nothing. There's got to be more. We're going to have something that's there when we get people to talk that people can access. And there are things now. Historically, there weren't. There are more things now. Andy's Man Club and Men's Talk, great examples of services that provide access to communities that can support men. The other issue is that a lot of men don't even know that they have a problem. They're blind to that issue. And they only know at the last moment, when there's very little time to do anything because things have grown to the point of crisis, that there's just no way to avoid it anymore. So some things are conscious, but other things are unconscious. Thanks.
Thanks, Luke. And Lucas, coming back to the talking groups, we've talked a bit about talking therapies. So how do your talking groups perhaps complement NHS services, but also what can NHS services, especially talking therapies, learn from the way in which you run, and Andy's Man's Club runs talking groups?
So I think they can be complemented by basically running side by side and encouraging people to basically open up, but in front of slightly different audiences. I think that our groups are built entirely on shared experience, as we've said. So the people who actually run our groups started off as group users in need of support, and then eventually became, leaders of the group themselves who received our training, to better facilitate conversation. I think that basically it's a case of people using as much support out there as is possible. I think that they can complement each other very, very well. The talking therapy groups and our groups themselves as well. I think. Are you okay to repeat the question? Sorry.
Yeah, just obviously talking about how talking therapists perhaps are not servicing men so well in London as they are women.
Yeah.
Is there something that talking therapies can learn by the way in which you run your talking club, talking groups?
Yeah. So I think that the way that our groups tend to work in terms of recruiting people are by just sharing individual stories that people will resonate with. I think that what a lot of men are looking for when they're in those positions of crisis is people they can relate to, and that sense of relatability. I think the way that we manage to recruit people and get people through our doors nationwide is by sharing stories that are representative of the areas that people are located in. I think, for example, we've just opened a group in Peckham in South London, and what we're looking to do is we're looking to share stories of people in Peckham that have been through, struggles, perhaps come through the other side, access other services, in the hope that it will encourage more people to access support. I think you face difficulty, obviously, in London, London being such a diverse place in terms of, socio-economic factors. But by just trying to basically get as many stories out there as possible and trying to, share as many stories of success, share as many stories of real life and real struggle as you possibly can, then you will foster that culture where more people want to attend, more people want to get involved, and more people want to come along. For us, I look at, the areas in London which we operate groups. We're in Hammersmith, Ponders End, Peckham, Romford, Barnet and Euston. The two most well attended of those groups are Barnet and Euston. In Euston, we've been able to link in with the venue, which is near Euston Station. They've been able to provide us advertising space where we've been able to share some of those stories, give people easy access to those stories. That again has boosted group numbers undoubtedly. In Barnet, we've worked very closely with Barnet Council. We've worked with borough councils across London, but probably the closest with Barnet Council. And what we've done is we've engaged with other services within Barnet Council, and that's enabled us to encourage people to actually attend. Again, I look elsewhere in the country at areas that have worked particularly well with us. I look at Greater Manchester as an example. We've worked with clinical commissioning groups across Greater Manchester, and we are an option for people who perhaps don't tend to find much benefit from the talking therapies that they offer. Equally, if people come to us and we want to refer back into public services, we're able to do so because of the relationships we've fostered there. But it is just that case of having that effective network of the services that are out there, encouraging services to work together, but also getting real stories out there that are going to encourage people that it is okay to go and open up about the issues that they face.
And so the Mayor has a rather substantial adult education budget, and from that there's courses like counselling, for example. Would there be, my wife's currently on one at the moment, and the vast majority of the people on that course are women. Would there be a better way to link up with, say, organisations like yourselves and others in London to perhaps promote maybe more of those group leaders to go forward and take more formal qualifications and crossover, or is some of that work happening?
Sam, sorry, go on. No, you go.
I was just going to say, I mean, as someone who has applied for the doctorate in clinical psychology, I have a slight envy of Luke, who is a success on that front. It is incredibly competitive to get into, and that is a huge barrier. We see a lot of clinical courses are really challenging for lots of different communities to access: men, people from lower socio-economic backgrounds, people from racial minorities. And that has a big impact because, again, it's less people getting into clinical training. Counselling courses often require you to pay extensive fees to do the training and then do free counselling and pay for your extra bits on the side. And these all mean that only certain types of people are able to access that kind of training, or you manage to get onto a clinical training course. So I think there's definitely a need to look at how we structure those kinds of courses, how we encourage people into the mental health workforce and make it more accessible, especially for men, because we do see that men do talk and they do talk to each other. But as Luke mentioned before, it's really important to then have a look at who they're talking to as well. We have a training programme for our volunteers. I know Lucas has already mentioned Andy's Man Club's training for their volunteers, and it is a big concern for us when we see services, charities come up, what level of training or input their volunteers have, their professionals, because again, we have that unique opportunity to reach men where they are. We have that catchment moment, but we risk also the fine line that we all tread in running services is between doing a lot of good and potentially doing harm. And I'm not saying that's a conscious decision, but charities have fallen into that trap by not necessarily providing spaces that or training or qualifications for their volunteers, for their teams, that help them to then help other people, help people in the space. So I think it's great to hear of the Mayor's scheme. it would be great to see if there's ways that that could take a more gendered focus and also a specific focus on different minority groups in particular anyway. But I think until we open up and allow that, I certainly know from the clinical doctorate point of view, there are thousands of men who apply for it every year and get knocked back. And there is an improving access committee that is looking at the doctorate as a whole. And they are doing work to try and address that, but again, in a more local sense, maybe in a London-centric way. Maybe that might be funded programmes specifically for men on other courses, counselling courses, things like that, to encourage men into the workforce, because it's something that lots of men want to engage with, but the access is not necessarily there. So, yeah.
Yeah, just to speak to that point, at Men's Rights Matter, we often have organisations approaching us, asking us how they can increase the number of men that are coming through their services, particularly if they're not specifically designed or promoted in ways that target men. And that may be increasing access to psychological therapies, NHS services, where the rates of access to those services are much lower for men, around 33%, I think, as Mark mentioned. Or it's other organisations that are looking to try to work towards bringing more men into initiatives that they think can help the men that are part of their communities. So it's a question, I think, that you have to ask each time you develop something that you want to try and kind of target men with, or offer to men, or try to bring men into because you think it's going to be helpful. So how do you get out there? How do you reach men in your communities to let them know that actually, hey, this might be of interest to you, this could be helpful to you because of X, Y, and Z. So it's got to be attractive, it's got to be there for a purpose. And I think as we begin to kind of really talk more around the issues that men and boys face, we give it a little bit more legitimacy to talk more openly about these things. And you see that taking effect a lot more now. There's a movement now that actually we're a little bit more open to kind of exploring this area. We're a little bit more open to talking around men and boys issues. We're a little bit more open to being able to express ourselves, our own struggles, our own insecurities, our own fallibilities, to be able to say, hey, yeah, I struggle too. And as you do that, the momentum gathers. And it builds and builds and builds. And it will continue to build. But as we do that, I think those conversations, just thinking about men in that way, how do I bring them in? How can I include them if I think it's helpful to include them? I think just asking the question is a really good starting point. What then the answers are to how you bring more men in, it's complicated and maybe sort of tricky to kind of then target and market or your services in a way that reaches out to men.
And perhaps coming back to you, Lucas, that's why there is this big adult education budget in London. We do offer courses like counselling. Is there a way to partner with organisations like yours to try and promote or try and push more men to see it as an option to get more men into that workforce?
Potentially, but I think from our perspective, you know, to take our charity as an example, we want people who basically are going to come and use the group initially as a first perspective, and I think that's where the focus would be. I think the way our model works is, you know, if the group users and the number of attendees increases, then the number of volunteers increases, and that's the way that our model works. But definitely, I think, you know, adult education, educating people that this is out there, and that basically, you know, there is an option to work in mental health. It will benefit us, definitely. I think, you know, from our perspective, even if that encouragement is to go and, you know, basically work in another service, or to go and contribute in another sort of way, it's going to benefit us in some way, shape or form. For us, there's no rivalry, there's only, you know, active engagement and working together. That's key. So from our perspective, it is something that will benefit us, you know, because ultimately it'd benefit our end goal, which is to reduce the rate of male suicide. But practically, for us, the encouragement would always be on people to attend first and foremost, and then those people, after they've attended and gone through that process, they will, you know, in turn become volunteers, hopefully.
I guess to grow on that point as well, though, Luke, I think you said it in your opening remarks around bringing us back to education and attainment for boys. Perhaps there's just wider work anyway in terms of getting more men to take on the adult education, adult education, and do more in general to market all courses to men. So,
I think just acknowledging that we need to talk about the well-being of men and boys is great. I think to hear that is refreshing, and for men and boys to know that there are people out there thinking about them, I think it goes a long way. We've got a lot of work to do just at the beginning of this journey, and that's the bit that excites me the most is, hey, there hasn't been anything going on. Imagine what could happen if we did do the work. Imagine what improvements we could see. And I think we're going to touch on the conversations that are around at the moment, and there's one conversation that I've been noticing a lot recently, which is about how men and boys are falling behind. And I think a better question is, a better statement is to say, wow, look at how much improvement there's been within the worlds of women and girls as a result of the effort and time that women have put into thinking around women and girls. The women's movement being around for over 100 years, thinking around the experience and inequalities that women and girls face. Well, there's a reason why they've been excelling recently. So I think boys have maybe remained a bit similar to how they've always been. Women and girls have advanced in many ways because people have thought about the inequalities that they face. So Men's Lives Matter, the project that I set up initially, was all about learning from that movement and saying, hey, if we replicated that work within men and boys, would it potentially lead to outcomes of benefit? And the answer's got to be yes, and we do have some data that supports that statement, which I haven't put out into the public yet, so I'll just hold it back, but I'm happy to share it with you. That if we think about men and boys, and we think about the experiences that are gendered to men and boys, and we start to address those, we're going to see the improvements, but it will take a bit of time.
Brilliant, thank you. I think Assembly Member Ahmed has a question online. She should come up in a bigger screen for you.
Thank you, Chair. I wanted to ask Lucas, just going back to something that he said a few moments ago. Lucas, you mentioned Peckham a couple of times, which is actually my constituency. And you've also, I think you've all mentioned actually on the panel about diversity and the issues that are faced particularly by men from minority ethnic communities. Lucas, can I ask you, and you've also mentioned Greater Manchester, what are you doing to address that particular issue in a place like Peckham, which is one of the most diverse areas of London, possibly in the country?
I'll probably use another place as an example, if that's okay. Again, I'll use Bradford in West Yorkshire, very, very close to home. What we've done in Bradford and what we intend to do in Peckham and in other areas of the country is we look at some of those diverse groups. In Bradford, we've worked with the Muslim and the Hindu Council to basically talk to religious leaders, to talk to people who are real pillars of the community already and lean on some of their influence to encourage people to come forward. For us, in a place like Peckham, we're an outside organisation that's coming in. We're working very closely with Pecan already, who do some fantastic work within Peckham. But in places like Bradford and in places that are very, very diverse, it's about looking at those existing sort of pillars of the community, looking at those trusted figures and looking at how we can sort of slot in and work alongside those guys. Because realistically, for us as a charity, going into Peckham, the only people who've actually got the experience of living in Peckham and actually, know what some of the struggles might be of that specific place are the people who live in the place itself. So for us, like I say, Bradford, we worked with the Hindu Council, the Muslim Council, we worked with Sikhs in Bradford before as well, and we looked at those places where people from those diverse backgrounds basically would traditionally go to support. I can remember having a conversation with imams before in Bradford about the fact that there an encouragement probably from some of the more old school, shall we say, imams that if men were struggling, they should try and become closer to God and they should try and attend the mosque more. and there's, you know, a new wave of sort of community leaders who are coming through, who, you know, are blending that sort of traditional approach that's been there for years, with a new approach of looking at these external services and basically encouraging engagement with them. I think where, obviously, you know, you guys can come in is you can foster some of those connections for us. We'll happily speak to anybody who's going to help basically encourage people to attend our group or to use any service whatsoever. But it's about looking at what's already there, looking at the people who are already making a positive difference, looking at the people who already have that influence, and looking at ways that we can, you know, basically be advocated by them in what they do.
Okay, thank you. That's very encouraging. Thank you, Chair.
Thank you. Assembly Member Wilson.
Thank you, Chair. First question is to Sam. So, I think, Lucas, you've explained about how some of your groups operate. So, Sam, this is about how your online spaces work. Keen to understand how that works, and in particular, kind of the differences and challenges, opportunities, advantages, disadvantages of using an online platform relative to sort of more traditional in-person discussions.
Yeah, thank you. So our online model works very similarly, actually, to the in-person model that Andy's Man Club have put forward, and I know that they also have an online group that's accessible as well. In I suppose broadest terms, it's a peer support model, so it's supposed to be peers supporting each other. That's what we encourage. We don't have quite as pure a model as Andy's Man Club, in that we have volunteers who haven't necessarily attended the group before, all male identifying, who come in and help us facilitate. We found early on that we weren't able to scale at the right pace to meet the demand from just having service users alone, and we had a lot of service users who wanted to remain in service and not necessarily volunteer, which is fine. And it's a case of finding every model that works for you and going for it, really. I think in terms of the benefit of having an online option is that we have national coverage straight away. So, you know, we talk about wherever you have internet, you have access. So a lot of the challenges that lots of charities face, and Andy's Man Club have done staggering work to address this in the scale of being able to set up, you know, 300 almost groups. It is remarkable. But that's a huge machine that obviously has to push that forward, and where that isn't necessarily something that a local community has access to at the moment, we can complement that and have ways that we can, again, start that conversation and bring people in. We regularly signpost to Andy's Man Club, to other organisations, but again, it's, as I mentioned before, it's that touch point. It's about saying, when guys find us online, but then they come to a group and say, actually, no, I kind of prefer an in-person group. We go, fantastic, let us show you one, Andy's Man Club. Or, you know, I'm feeling a little bit more in crisis. The previous panel mentioned James's Place. There's the Listening Place. There's so many organisations doing excellent work. I think the online element is that we do actively reduce some of the barriers to access. Men who can't necessarily physically access in-person groups, those with caring responsibilities who might not be able to travel or leave home. There's an element of stigma still, unfortunately, with attending in-person groups, in the level of fear maybe around being in person. Whilst we encourage, we require everybody to sign up through our website, so that we can track numbers and so that we can just ensure that the groups don't oversubscribe and become uncomfortable and less useful for the guys attending. We do allow the guys to join the Zoom call with a pseudonym, with their camera off, so we have that element of anonymity that can help, again, just bring them into a service. We've found in 99% of the cases where a guy comes and joins one of our groups with his camera off and a pseudonym, that lasts no longer than 30-35 minutes. It's just a comfort thing. It's just getting into the space. You know, Andy's Man Club have, if I'm correct in thinking, tackle that by having the men kind of outside the space, literally welcoming people into the building, into the environment. We kind of do that in a digital sense by creating that anonymity, and our volunteers then find ways of keeping them safe and talking to them and making sure that they feel okay. So there's huge benefits to having an online model. It doesn't work just on its own. We complement it with, you know, all the other services that are available, but we do see that where men can access communities across the UK, that's also beneficial. We have guys joining us from the top of Scotland, across to Northern Ireland, you know, down on the south coast, and people that they wouldn't necessarily have access to, communities that aren't necessarily their own, that don't look like them, sound like them, and it helps foster interesting conversations and that little bit of diversity that just can, again, sometimes pull focus away from an individual issue and bring in a community feel, which is what we're trying to, much as Andy's Man Club has done an amazing job building their community, we're also building a digital community that, again, can complement that and is a space where men can come and talk.
Fantastic. Thank you very much indeed for that. And then I guess a follow-up to both Sam and yourself, Lucas. So when you're running these sessions, and what do you find some of the key challenges that the participants highlight about their mental health in both these settings?
Yeah, so I think it's very representative of the area that you're in, potentially. So I've spoken earlier to a few of the group leaders in London specifically. Work and the work-related stress that they're facing is potentially the biggest thing that people are dealing with in London. That came across constantly. I think that the workplace culture quite often in London can be quite different to the rest of the country. In that it's you know, can be a lot more fast-paced, and you know, the community aspect that a lot of workplaces have, I don't think is quite there. I think in certain places in London, especially when you consider that so many people are commuting out, you know, from outside of the boroughs into London itself to work. Conversely, I spoke to a few of the group leaders in Essex, Berkshire and Surrey as well, and they were facing the same issues. Workplace-related stress, workplace-related issues were sort of top of the list, and they were closely followed by cost of living issues as well. So it does tend to be very representative of the area. Interestingly, we do run those online sessions as well, like Sam mentioned, and a lot of the people who attend online, social isolation is the biggest issue that they face, and that quite often is due to their life circumstances. But yeah, workplace related stress, cost of living being a big driver, some of the biggest issues that people are coming forward with in London. In the rest of the country, you'd probably say anxiety is key. Anxiety and then stress about particular, you know, life circumstances, often related to finances, relationships, that type of thing. But yeah, a real focus on work culture in London.
Yeah, I mean, much the same at Men Who Talk as what Lucas just mentioned. We do see work-based issues, problems, stresses as a significant topic that comes up of conversation. We do see that relating very closely to finance, and that maps out in a lot of kind of nationally available polling data, survey data around the key issues that impact men's mental health. Specifically in the online space, we do see a lot of the loneliness that comes forward a lot. We have men accessing us who just have lost a community, haven't necessarily found their place, and are looking not necessarily for a complex load of mental health support, and that's why the kind of lighter touch, earlier intervention provides just that community space, that connection. We don't call our groups support groups, we call them social spaces for men to connect. Because we know that the word support is particularly loaded. Lucas mentioned it earlier towards the beginning around the fact that many men feel that they have to have a diagnosis, they have to have a certain level of challenge, and actually we're trying with our services to say, no, you don't. You can come and access us, and it's great to come and talk to us at any point, and we want you to socialise and actually look at being mentally healthy. So loneliness is a big element. We do also see some interesting conversations that come up as relatively regular themes around sexuality, and not necessarily having had space to talk about complex thoughts around sexuality, and needing a space. A lot of shame as well. I think men, particularly coming into our online groups, feel that the element of anonymity, the element of national distribution, helps them talk about topics that might be otherwise shameful. So we talk about pornography addiction, some physical health things as well. We had a really interesting group where someone talked about testicular cancer, but he'd been so ashamed of talking about checking his testicles that he just couldn't talk to anybody in person about it. And then he came to the online group, and all of a sudden everyone's talking about how great it is to go and check your testicles and to get your prostate checked. And it was a magical moment of just this one shred of honesty. It helped to really encourage that. So we have lots of outlier kind of topics and themes which really provide an interesting lens for our groups, because they're things that just really have such a high level of stigma and shame still, unfortunately, to talk about, but they are pervasive issues that are being running as an undercurrent. The previous panel talked about violence against women and girls. We know that pornography is a huge issue around over-sexualised violence and things like that. But if we don't provide a space where men can come and talk about it, especially when they're being largely blamed and labelled and really targeted in the media, if we don't provide an early space to talk about that, we're only ever pushing them right up to the end, as Mark mentioned, where they then eventually end up committing offences or end up getting to a space where they're then seeing negative help-seeking behaviours, which is, is not something we want to see. So we do have those core themes, but we also have lots of outliers, which I find really fascinating, and I'm very proud that Men Who Talk has had that to a degree.
Just very quickly, final sort of question for me. The content of your groups, are they, is it very sort of confidential, so sort of what goes on in the group stays in the group, and people are obviously not encouraged to then share it more widely?
Yeah, I mean, obviously we have a duty of care, safeguarding, and we have our very robust ways of making sure that our attendees are as looked after as possible. But certainly what's spoken about in the group is kept in the group. That's really important. Lots of the previous panel talked around trust, and we've alluded to it already. It is a huge thing for any guy to reach our group. They will have often had many different touch points with different organisations, many different things that have happened, and we may well be their last opportunity to have a trusting relationship. And the magic, as Lucas said before, around when we see guys coming into our groups and then going and accessing other support because they've found that trust again, is impactful beyond measure, really, and we won't ever be able to measure it. But it starts with that ability to say, this is a trusting, safe space. It's what we do collate feedback. We get feedback from our attendees after they finish, and 95% of those who attend a Men Who Talk group reference the non-judgmental element, the privacy within the space, the supportive social element, as a really core reason as to both why they came and stayed for the group and why they would consider coming back in the future. So it is a really important element for sure.
Can I just build on that, just because the experience we have in London schools running Becoming a Man with 11 to 14-year-olds, the issues are not necessarily the same that come up, but it's the same ingredients, it's the same trusted adult, it's the same safe environment, it's the same permission to be able to narrow the gap between your external reality and your internal reality. And you say, hey, it's all right. And within the Becoming a Man programme, which was something that we brought over from Chicago, and has some really great evidence to it, and some real basic principles that are teaching young boys about respect for womanhood, about positive anger expression, about the power of empathy, about visionary goal setting. These are basic sort of male-gendered principles that teach, and the kids that basically are coming through that and using those principles to talk about struggles with academic achievement, being able to deal with the ups and downs of everyday life. A lot of it is family relationships, a lot of it is relating to shame, a lot of it is relating to how they deal with conflict in their lives. And the saving, you know, and I just wanted to say that, like, you know, what we're finding is that this is trained counsellors in schools in a non-clinical context. We're finding it works, we've got the evidence, but we really struggle with the scale and replication of that work. It's expensive, so people are not buying it. And effectively, the system is saying that the cost of investing in the formation of our young boys is not worth it, and then we end up with all of the consequences of that later on in life, both in terms of people's individual mental health and the quality of their psychological experience, but also obviously the societal implications.
Thanks. Mark, I just want to ask briefly on that. You say people almost aren't buying it. Does it feel, perhaps being in that space, that almost men's mental health, or, you know, boys becoming good men isn't a flavour of the month or something that people... Is that a problem, or is it just a general...
I don't
kind of public
no.
finance that problems that everyone in a charity or running.
Yeah, I'm not going to sit here and say if we were running, because there's an equivalent program called WOW, which is focusing on young girls and women. It's not like that program is being scaled exponentially, but the one with boys isn't. But we are finding that across, you know, these are boys that the school are finding are struggling in lots of different ways, and it's got really good evidence in terms of reduction of exposure to the criminal justice system. But what we're finding more generally is that those early intervention, prevention, public health interventions that say actually we're going to invest up front in formation and giving people the skills and understanding and knowledge is not being invested in at any way the level that another social issue is. So the whole system is pivoted towards urgent and emergency rather than upstream and prevention. So we just don't find the public funding to be able to replicate any of the work that these guys are doing. The priority isn't there. And one of the messages I wanted to leave for London was challenge yourself to be saying, where is the balance of spend between what is being spent on mental health services versus what's being spent on upstream preventative measures? And even a 1%, 2% diversion of funding could have a really big impact in terms of downstream impact.
Thank you. I think Assembly Member Ahmed is the next question.
Thank you, Chair. Before I get to my official question, could I just ask Mark a question about the Becoming a Man project and the initiative? Mark, we keep hearing about the toxic influencing, and actually I don't call people like Andrew Tate influencers. They are misogynists, and I think they should be called out for that and actually given the label that they actually are and what they actually put out there. How is your Becoming a Man project counteract this? Are you finding it helpful, or is there more that needs to be done?
Yeah, thank you very much for the question. I think one of the themes that comes through the group is this idea around the false promise of easy success, and the idea that you can have a life without problems of just unvarnished success where you get everything you want. And I think that comes back to effective role models, and one of the things the programmes do. I mean, the counsellors themselves are really fantastic role models of showcasing honesty and vulnerability and how to deal with shame in a healthy way. It is an issue that is really intoxicating for young boys, to be given a promise that you could achieve fame, success, money, and sort of all the things that you want if you just drink the elixir of blaming other people for where you've ended up. And one of the principles within the Becoming a Man programme is around individual personal responsibility and accountability for you and for your actions. And one of the principles is this idea of your pain, maybe it's not your fault, but it is your responsibility. How you act on that pain and what's happened, help to understand it, but take responsibility for it. But kids need, that's a skill. Like if you said to a brain surgeon, perform brain surgery, but we won't give you the training, just go and do it. And somehow we're expecting young boys to be able to deal with these incredibly high... So part of it is unpacking the high expectations, the false promises, but part of them is teaching the basic emotional skills of understanding your own emotions, how to check them, understand the drivers, and then have some sort of degree of mastery over the choice of your response. And it's that is the Becoming a Man programme teaches the skills that young boys need. And once they have that, they've got some power to be able to resist the all too easy false promises of the Andrew Tates of this world. So it's really emotional skills that are needed.
And how is that landing?
Really well. It's got really great results for the evaluation. It's got really good evidence from the Early Intervention Centre. It shows really good lasting impact in terms of noticeable impact in terms of educational attainment, notable impact in terms of emotional regulation, motivation, understanding of mental health, and it's got good impact in terms of the observed benefits from parents and carers. So it works, but it needs investment.
Okay, thank you. So my question now is to Luke. Luke, Men's Minds Matter has developed a model of psychological entrapment and suicidal crisis. Could you explain to us, please, how this worked, the impact it's had, and what other key suicide prevention initiatives is your organisation delivering?
Yeah, thanks, Marina. Just to mention, I also live down in Peckham, so if you want to grab a coffee or something at some point, I'm happy to do so.
All the best people live in Peckham. All roads lead to Peckham. I keep saying this.
I think there's good people everywhere, so hopefully. So, Men's Minds Matter. I'm a clinical psychologist. As I say, I've worked face-to-face with people that are actively suicidal, not just having thoughts, but plans and intentions, or have actually acted on those. Primarily within the NHS in crisis teams, seeing people in their homes as an alternative to hospital admissions, trying to help them resolve the problem of suicidal intent. I've done that for a long time, probably one of the few psychologists that have spent so long within those services. And what I noticed is that the way that I worked was similar for everybody that I came into contact with, regardless of whether they had a diagnosis or whether they didn't, regardless of what that diagnosis was, regardless of how complicated they were or uncomplicated they might have been, whether they had past traumas going back to their childhood or whether they didn't. It didn't really matter whether they're male, whether they're female, what ethnicity or background they came from or identified as. It didn't really matter. That it seemed to be that working with somebody who was suicidal, I would end up doing the same thing, which said to me is a problem in its own right. Now, the problem with the NHS, from my perspective, when you're thinking around suicide, is that you're thinking about it with the wrong model, that the NHS is built on a model of mental illness, of ill health. And it's a very poor way of conceptualising suicide because mental illness is not a predictor of suicide. It doesn't show much association. There's a slightly elevated risk with some disorders, but not much. The vast majority of people who end their lives do not have an identifiable mental illness, nor would they have one if somebody assessed them, nor would they even identify themselves as being mentally ill. So there's got to be something else going on. I really love the conversations today because what we're talking around is real life experiences, things that happen in people's lives that lead them to the point where they experience something so distressing that they'll do anything to get away from it. But suicide is a resolution to emotional pain that is unabating. It doesn't go away and it sticks around. And all the attempts that they have made to try to resolve that emotional pain or psychological distress hasn't led to any resolution. In fact, things have got worse. The pain has got more intense, the distress has got more intense. Now I'm more likely to turn to that option of ending my life to escape him. There isn't a psychological model that clinical psychology or other forms of psychological therapies has to conceptualize the suicidal experience. It's often seen as a symptom of depression, for example. But there's loads of other things that can contribute to why people end their lives. That there are other experiences that people have that aren't depression that also account for potentially why people end up at the point where they want to end their life. Now, understanding the processes that lead to and maintain suicidal thought planning intent at the level of the individual, i.e. what's going on in my own psychology that's leading to the point where I'm willing to end my life, my experience led to the observation that there wasn't anything. And with my experience of working in crisis teams, knowing that there wasn't anybody else out there that had that experience, it landed on me to go, well, I think I've got to develop one. So around about 2016, I started doing that. And I was joined in 2018 by my co-director and our lived experience lead, Nigel Sanderson, who himself tried to end his life in 2017. Nigel was a great friend of mine. I met him at university in 1998. Now, he came on board with Men's Minds Matter with that lived experience once he recovered, once he got to a point where actually he was in a position where he could consider sharing his experience. He came alongside me and he told me his story, and I helped him think about how he could take that story as a lived experience, lead to share it with the world to help others who might be struggling. And he thought that that was a good idea. Now, as he told his story, I mapped our model, the model that I had onto his experience, and I said, oh, Nigel, what you've described there seems to be what I would include within the model, and psychologically I think this is going on. What do you think? And he'd turn around and go, oh yeah, I like that. That kind of sort of really sings to my experience at the time. Or he'd be like, well, I think it's a little bit like that, but it might need tweaking. So the model's been co-developed with my experience as a clinician, which is quite unique, and then the lived experience of Nigel, who's been there. He's been at that point where he did try to end his life. So the model's very unique in the way that it's been developed. It's the only model of its kind. I've used it in the NHS crisis services where I've worked. It's built on already existing evidence-based practices, but it's not evidence-based yet in its own right. In terms of the people that it's helped within the crisis services where I've worked, my experience tells me that it does save lives, that it accounts for what's occurring within people's experiences, because people turn around and say, wow, nobody's ever explained it to me in that way, but that literally is my experience. So the model itself has validity within my own kind of application of it within clinical services. In terms of how it, in terms of where we go now and where Men's Minds Matter sits, is that it has a model that defines the mechanisms that lead to and maintain suicidal thought planning and intent. With that model, we now have a map that can provide the answers and the resolutions that will lead people away from that experience and into something that will be safer and hopefully longer lasting. I can see what the problem is. Now I have some tools and skills not to go there again, because I can see that actually it's not something that I need to consider in the way that I used to. So we have a map. And that map is what Men's Minds Matter is now being, is what Men's Minds Matter uses now to build out the suite of interventions that we think are going to save lives. We're in the early phases of that. We only launched the model in 2021. Since we launched the model, since we started telling people about it, we've started to grow at a rate that is much bigger than we've grown previously. But bearing in mind, we're still only 2.6 whole-time equivalent employees. That Men's Minds Matter has been run without money for over a decade. We now have some money to bring in to employ 2.6 people. You have helped around about 1,000 people that are actively suicidal. Not just that, we've helped people that are bereaved by suicide that get in contact with us, not because we're funded to do so, but because we have an obligation to step up and do something about this. We have an intervention that we think will save lives, but we need to scale it up. Now, we can do that, and we will do that. We have a strategy and a plan to take it forward. We have some money in the bank to be able to start developing the interventions that we can present through digital platforms. But we can do much, much more. And the more that we have in terms of finances, the more we can do to get that intervention out to people sooner, quicker, faster. So it's a really exciting time for Men's Minds Matter. I've been doing it a long time. It's kind of like a hobby for me in the beginning. But now it's serious. Well, it's always been serious, but now it's getting more serious. And we're not messing around. We've got something that we think will save lives, and we're not shy about telling people about that. We'll do it anyway. We'll get there in the end. But the more support we get to achieve our ambitions, our goals, and to get that intervention out to people, the better. We are working to evidence-based models. We're working with Liverpool John Moores University and Teesside University, who approached us actually and said, we really like your model. We think that actually there's a partnership here that we can take forward to the future, where we want to do the work to help evidence-based what you have. It's super exciting again. So we take a really unique approach. The model itself is very exciting. It underpins everything that we do. I'm happy to tell you more about what we do at another time, because I don't want to take up all the space. But
Thank you very much, Luke. You quite rightly pulled me up. Of course, the best people live everywhere, but it is my job to promote my constituency. Thank you.
Thank you. Assemblymember Harani.
Thank you. It's sort of a catch-all. It's a question for all on the panel. So maybe I'll start with Mark on the left in answering. But what do you see as the role of the Mayor of London in supporting men's mental health in London? And what further action would you like to see him take?
Yeah, I mean, I think it's a great question. I wrote down a number of different things that need to be taken. I think what you've heard here is that there's a huge amount of innovation going on in the voluntary sector. There is a risk that men and boys' mental health there's not enough research, there's not enough innovation, there's not enough customisation, there's not enough co-creation with that population, which I think if it was the opposite way round now, we would see much greater. It would be a cause of much greater alarm, much more concern, and I think one of the reasons why those influences like Andrew Tate and others gain influence with young boys is because we do need to feel like every single one of us needs to feel like we matter. And so I think what the mayor can think about is firstly affirming that every single young boy and man matters in London, and make sure that is. And so I know time is short, but we've talked about the importance of promoting mental health literacy and normalising vulnerability, the formation of what it means to be a human being and from a gendered lens, I think is particularly important. So that not just redefining of masculinity, but expansion, understanding, curiosity. I think there's a lot more that could be done with the interventions that we've talked about today early on, that could be done both in schools and at a community-based level. I think there is a lot more that London could do to expand and utilise technology. We've talked about online platforms. We do think that AI-assisted technology is something that needs to be explored. It could have a potential for men disproportionately to be able to give them access to psychoeducation and support and advice that is confidential and shame-free, because it doesn't have to be with anyone. So testing the potential for AI to be able to give much greater access and stigma-free support is something I think is really good. But there's a systems reform point, which I mentioned earlier on, which we did a study recently about local authorities in every 42 integrated care systems across England, looking at how much they invest in mental health prevention and whether they've got a plan, whether they've mapped what the needs are, who the high-risk populations are, what interventions are working and what they could invest in, restoring their public health budgets. And I think the number one message is that we need to take a public health approach to men's mental health, and we need to have a plan for preventable harm, and then have appropriate co-created services that are relevant for men when they do get into that urgent situation and need help. But I would like to see London challenging and showing the way for those that wider preventative plan and strategy.
Yeah, thank you. I think it provides a really useful opportunity to have a look at the challenges that we face as a sector, as charities, you face in terms of policymakers, and I know that it's always challenging balancing the act of all the different policies and all the different areas that you cover and trying to prioritise things. I think London, as Mark has said, has a really unique opportunity to lead the way in a lot of innovation, and the Mayor can help to spearhead that. I think we actively at Men Who Talk try and talk about the fact that we need to see men as whole men, not just mental health and physical health and their work and their home life. All of these individual compartments, when we compartmentalise people, we lose the bigger picture and we shove people into siloed services that are, let's face it, not often well connected. What we need to do differently, and what policymakers, in my opinion, and the opinion of Men Who Talk, need to look at, is how we link all of that up to see the man as a whole, as a bigger picture. We've talked about work, life stresses, about finances, about preventative public health, public mental health programmes. These are really important. We need to see men in a holistic sense, and the services in a holistic sense. I would love to see London connecting up not just with homelessness, but financial services, and integrating all the work that we're doing right at the bedrock of all of that. Not just seeing citizens' advice as a financial or a particularly legal service, for example, but helping us connect up with the mental health elements and helping really link everything in. So I think the Mayor can, I would hope, take a lead with that, and we would certainly offer our support to any programme in that sense. I think, as Mark mentioned, we have to have a systems change to see mental health beyond a crisis. It is critically important that we have those crisis services, and we don't have enough of those. I want to make it plainly clear. I'm not advocating for those services to be shut, but we have to start having a conversation about how we encourage men not just to survive, but to thrive. When was the last time we collectively or individually said, my mental health and well-being is really thriving? I can say personally, it doesn't often happen, but we need to have that focus, and the Mayor could help us connect up with programmes, connect with each other to really move that forward, and to create that systems change, and London could lead the way in that. So, yeah.
Yeah, so I think, so I'm getting used to that, to encourage and facilitate collaboration between different organisations that work in the same sphere. I know hopefully some of that will have started today and it can continue to happen. But, you know, basically opening up his network to us, people who we can, you know, form those connections within those local areas, not even necessarily in the same sphere as us. Like I mentioned, the work we've done in Bradford, you know, that's work we could do in other areas of London. And then to look at more practical stuff, you know, that the Mayor could do potentially. More engagement with, you know, with public services like TfL, for example. So, I mean, one thing that we've done across the country, we worked really closely with transport companies, particularly the railways, the rail industry, got in front of staff, and then advertised through the network as well about our services and about other services as well. Basically, you know, when it comes to mental health, in my opinion, there should be services, you know, that are visible absolutely everywhere possible. You know, I'm envisioning walking into tube stations, for example, and seeing, you know, a Mayor's directive for mental health or different services, all, you know, on the advertising boards instead of whatever plays on in West End next week. You know, stuff that's going to make a meaningful change. I think if we look at as well stuff that's happened elsewhere in the country, we're working closely with Andy Burnham at the minute in Manchester, and Andy Burnham's coming up with a plan which is all around creating a directory of mental health services, where some of the funding that I think has gone previously to the private sector will go to charities that are basically mopping up a lot of the work that's falling through the cracks of the public sector at the moment as well. So maybe having a conversation. Apologies, Mr. Burnham, if I've passed on your idea there. But that's the point that I'm making. I think, you know, that collaboration, looking at how we can, you know, basically help organisations like ours to grow and to thrive, and then the very real stuff, you know, different council areas coming together to work together to advertise on bin lorries, you know, stuff like that, stuff that just seems, you know, quite extravagant, but it's basic, and, you know, realistically there's nothing that works better than just putting something plainly in front of somebody's face and encouraging them to go and use it.
That's fine. And yeah, on this committee, I think public advertising on the public estate comes up quite a lot as well. So thanks for reiterating that as well. And Luke?
Yeah, where do I begin? One of the issues that I was aware of when I started developing a model that looked at what was occurring at the level of the individual in terms of their suicidal experience was the dangers that could arise from locating the problem within the individual. Now, we need a psychological intervention that defines the mechanisms that lead to and maintain suicidal thought, planning and intent. That's why I developed one. But suicide is a complex problem. It's multifaceted. And a lot of the problems aren't located within the individual. They're located at a more macro systemic level, at a more policy-driven level, around the associations between economic deprivation, financial insecurities that occur very quickly when you overstretch people, or when you create a society where there's a huge wealth gap, or when you create a society when actually your access to being able to support your daily living needs has been eroded over time. These are big problems, and we know that one of the biggest factors associated with increased risk of suicide is financial instability and economic deprivation. This is a societal problem. It's a macro level problem. And developing an intervention that locates the problem in the individual could potentially be, well, the person has to solve the problem themselves. No. There are systemic issues that contribute to the distress that people experience, and that's what the mayor is here to do, right? Is to think about the communities in which we live, about the values and the way that we want to come together as communities, not to pursue our own selfish interests, to promote our own gain, but to support other people, to leave no person left behind, to, yes, let women and children go first, but hey, let's not leave behind the men. Now, I'm really happy that this has happened today, and from the beginning of first researching and looking into men's mental health in Southwark and finding nothing, I find myself here before you. Wow, what an amazing thing. I get really excited about this work. I'm a man, you know. I suffer in the same way as other people. I like thinking about my own psychological life. I have two young boys, 7 and 2, and guiding them into their manhood is going to be, wow, what a journey. Hey, I'm super excited, and big shout out to my boys. I'm excited. I'm excited about this stuff. So I'd encourage the mayor to get excited about it too. Hey, we're in the business of saving lives. It's not a business that creates a lot of wealth, but wealth isn't important here. It's about health. It's about people's lives, and we need to save people's lives because we've ignored this problem for too long. So great that he's getting involved. So super happy to see where this goes in the future, and happy to contribute at further points should you need me to, or Men's Minds Matter.
Thank you, and thanks to all the guests today. We're going to be writing to you to ask for some feedback on the National Men's Health Strategy and things that you think should be included in that. So if you could respond, that would be amazing. But thank you for all your contributions today. We really appreciate it. There's just a couple of things, and we'll wrap up. So can I just ask the committee to note the report and today's discussion?
Noted.
And to delegate authority to me as chair in consultation with group lead members to agree output.
Agreed.
Thank you. On the Health Committee work programme, can we note the committee's work programme and its meeting dates as agreed by the London Assembly at its annual meeting on the 6th of May 2025?
Noted.
The date of the next meeting is on the 2nd of July 2025, 2 p.m. here again, and there is no urgent business, so I can declare this meeting closed. Thank you.